So it seems YouTube is okay.
Yes, we are on YouTube now.
Okay. Tayfun, please tell me when to start. We will start 1 minute later. The webinar will be completely open 1 minute later. Dear colleagues, so all of you are welcome. On behalf of International Basic Neurosurgery Course Organizing Committee, it's our honor and pleasure to see Dr. Lawton, Dr. Giuseppe Lanzino, Dr. Türen Başkaya in Ibnc Webinar 5. I think there is no need to introduce them, but I must say that they are not only distinguished neurosurgeons, but they are also very good teachers. I'm sure today we will learn many tricks that will help us in operating room. I want to thank them by heart to be a part of this webinar and a member of Ibnc family. This webinar is also shared by Neurosurgical TV by Dr. John Bennett. I also have to thank to him for his cooperation. I also thank to Turkish Neurosurgical Society members and all participants for their full support to this a wonderful meeting, and I want to invite Turkish Neurosurgical Society President, Dr. Emel Avcı.
Thank you, Professor Emmez. And it's my pleasure to be here in this wonderfully organized meeting by Professor Emmez and his great team. Turkish Neurosurgical Society has given massive support to Ibnc since 2012. During these years, we have established huge Ibnc colonies all around the world. Now, finally, we are incredibly excited to be able to come together with our great mentors, Professor Lawton, Professor Lanzino, Professor Başkaya, and Professor Türen in these hard days. Maybe we can pass these difficult times more easily by remembering the words of Yaşar Kemal, wise man and prominent writer from this landscape. What can one do but accept the power of being challenged? We as humans have got to where we are by taking these hardships head on. without further ado, I will now hand it over to Professor Bashkaya, who will be moderating this spectacular meeting. Thank you, Professor Bashkaya.
Thank you, Professor Avcı. And first of all, congratulations on your presidency. I should call you Madam President.
Thank you.
And also, I'd like to thank Professor MS for organizing this. And most importantly, distinguished speakers, Doctors Lawton, Lanzino, and Ture. So, and also whoever participating from all over the world, good morning from Madison, Wisconsin, wherever you are, good afternoon or good evening, and we will have a wonderful time. So if you have any questions, I think, Hakan, we should do each speaker and then the question after that speaker, or questions after all?
We can take questions after all speakers, and
Okay.
ask their questions from QA. And I think Dr. Lawton has limited time. That's why maybe we can take one or two questions for Dr. Lawton.
Okay. And if Dr. Lawton has a limited time, I think we should start with him, or Dr. Lanzino, whoever. So
that's okay. You can keep the order. I think if I go on time, I should be fine.
Okay. You always do. You stay on time. The problem is me not staying on time. So, but I'll be the last, so I won't disturb the order. So first speaker then, Professor Lanzino from Mayo Clinic, Rochester, Minnesota. He'll be talking about the tricks in AVM surgery. Giuseppe, please start sharing your screen.
Thank you. Thank you, dear colleagues and friends, for the kind invitation. And in the spirit of Ibnc, what I'll do, I will go through some of the basics of AVM surgery. Now, I think there is no other pathology than AVM surgery that better characterize our specialty. It's a combination of psychology, planning, strategy, and then, of course, you have the execution. Now, all my teachers have always stressed never underestimate an AVM, never go into surgery, no matter how easy the AVM might look on imaging, thinking that it's going to be an easy day, because your psychological state is very important when you might need to be faced with bleeding, and that's of course extremely important when you are dealing with a complex AVM. That day you really psychologically need to be ready for a fight. One of the fathers of our specialty, Dr. Drake, is quoted to say, AVMs are nothing but hard work. And there is some truth to this, to his comment. Now, some of the basic things, like nowadays, there is a tendency to try minimal invasive and keyhole approaches, but like large convexity meningiomas for complex AVMs, big craniotomy, you need to have full exposure of the subarachnoid spaces, not only of the AVM in the superficial cases, the draining veins, but also, more importantly, also to have a full view of the surroundings. And it becomes particularly important toward the end to have a full exposure of some of those, what I call the secondary draining veins, because sometimes you might be left with, after excision of a large AVM, you might be left with a small residual hidden AV shunt. And the only indirect sign might be that one of those secondary draining veins around the surface of the AVM might still feel early, and that's something that you can diagnose with the ICG at the end of the procedure. Now, visualization is key, and to have a beautiful view of the subarachnoid space is key. So nothing worse than ruining the execution of the surgery by having a subarachnoid hemorrhage caused by inadvertent damage of a vessel as you are opening the dura. So open the dura under the microscope very carefully, and especially in AVMs that have ruptured before, there might be very small dural vessels that have been parasitized by the AVM, and sometimes these dural contributions might even be difficult to see on the preoperative angiogram. ICG fluorescence is not necessary. The main limitation is that, of course, sees what the microscope sees. But again, it's like any other technological adjunct. If you have available, adds very little to the time of the procedure. It's very safe. I would go ahead and use. It allows you to have an additional confirmation of the feeding arteries, draining veins, angioarchitecture of the superficial portion of the AVM. And it can be useful at the end of the procedure or as the procedure is progressing, also to identify possible areas of residual shunting. Now, one of the main issues that I have encountered as I started doing AVM surgery is that you see some of the nice drawings in the books, and this is an ideal conic AVM from the surface with the apex down to the ventricle. But what I found over time, that one of the key and most difficult parts, especially in complex AVMs, is to stay right at the boundaries of the nidus. And quite often you have AVMs like this that are like an iceberg, are partially hidden underneath the cortical mantle and the subcortical white matter. Or you have AVMs where there are the so-called Hashimoto loops, that are these loops of nidus that leave the nidus, they go partially into the subcortical white matter, and then they go back to the AVM. So really staying at the boundaries of the nidus with the cortex and the subcortical white matter, and not getting into the nidus at the same time, minimize brain damage, is really one of the key features of the entire dissection. So for this purpose, it's very important to open as much as possible at the beginning of the surgery, to really widely open all the subarachnoid spaces surrounding the AVM, and really unfolding those subarachnoid spaces. And this phase of the surgery is critically important to get adequate atraumatic exposure. Is facilitated by the fact that the draining vein is thickened, it's arterialized, so it's fairly resistant. And often the arachnoid, it's also thickened. So this part can be done safely. It's a very important part of the procedure. But I found it very important also from a psychological point of view, because you start and there is no bleeding, and you do anatomic dissection, and we all love what we do, especially when we're working under the microscope. You get into that flow of the surgery. And that's what Dr. Lawton described in his beautiful book as the calm before the clash. And it's really an incredible description of how you feel and what's going on. And for complex AVMs, I remember very well one of my mentors saying at the beginning of the resection, you often might feel like you are the best neurosurgeon in the world, but also you need to be ready. And at meetings, we tend to show edited videos, but you need to be ready that toward the end of the resection, that feeling might be gone, and it's you might be left with dealing with the situation like this, where there is bleeding. The field is not quite as nice as it was before. And then there are some situations where toward the end, you are faced with the bleeding, and the best thing to do is to resect the bulk of the AVM and deal with the bleeding afterwards. Now, another important concept that helped me, as I said, the psychology is a big part of this surgery, is that during a complex AVM surgery, a few times you might be faced with the bleeding that is really difficult to control. And don't underestimate the fact that you are concentrated, you're focused, you're working under the microscope under very high magnification. So the amount of bleeding, it's also exaggerated by the microscope. But what has helped me a lot over the years is what one of my early chairman, Dr. Hellwood, told me, said, when that happens, remember, you have done it before. It's not the first time. And in the vast majority of cases, you have been able to deal with it. So knowing that that's an expected and the normal part of the operation, and knowing and remembering that you have had the same feeling before, it's very helpful as you are trying your best to deal with some of these tedious bleeding. Now, as I said, one of the most difficult parts for me has been really to learn in complex AVMs, and every time to find out really that magic spot between usually the white matter and the nidus, and really strike that fine balance between staying at the border of the nidus and avoid as much as possible any brain manipulation. And I think that's something that you need to be cognizant. You need to really have studied the anatomy of the AVM. I found it very useful to study not only on the angiogram, but for this particular part, to really study and really get a fix in my visual memory, the T2 MRI. I found it very, very helpful. Now, deep feeders are a problem, are one of the main problems, particularly because they don't respond very well to traditional coagulation. The wall of the vessel is abnormal, and they are encountered in the latest portions of the procedures. Now, there are some tricks to deal with this problem. First of all, the worst thing you can encounter is to have one of these feeders, as you are coagulating, it starts bleeding, and you have a very short end, and it will retract into the white matter. And then you may end up with the hidden intracranial hemorrhage or intraventricular hemorrhage. So it's important as you are working around these feeders, you see them, resist the temptation to start controlling and coagulating right away. Instead, isolate an adequate length of feeder from the white matter. They respond well under a situation of flow arrest, and I will show an example of what I mean by that. And what Ernest Yemi has been popularizing, the so-called concept of dirty coagulation, is nothing but when you are dealing with the feeders, leave a little bit of white matter on each side of the feeding artery, so that your bipolar blades are not in direct contact with the vessel wall, but there is some white matter in between. And this seems to facilitate some of the dissection in this phase. So here is a situation. You can see it's an older video, but you are in the later phase of the AVM dissection. There is a deep feeder. So you make sure you isolate a decent length. You try to coagulate, and you can see that it's like the bipolar is not working at all. And when you try to coagulate, try to stay again as much as possible toward the AVM side, so that if anything happens, you have an adequate length. But as I said before, these feeders, they respond better to coagulation under a situation of flow arrest. So one of the tricks is to put one of those mini clips and then try to coagulate afterwards. And you can see that now the coagulation can be effective. I try to avoid, you can see in this case was really at the very end of the resection, but I try to avoid as much as possible the use of mini clips, because the last thing you want is that to have your field filled with the mini clips around the AVM, and then if you have to deal with the bleeding, they might be on the way. Another trick to minimize having any trouble from these deep feeders, so like you see in this situation, is that after you have coagulated, you are under the impression that you can see leave a little bit of a tail toward the white matter, stay on the side of the AVM. And as you cut that feeder also, you want, instead of going directly completely through the entire wall, just cut about 2/3 of the diameter of the feeder, so that in case, like in this case, don't cut it completely because it might retract. Cut about 2/3, so that if there is any residual bleeding, then you can deal, and you don't have a feeder that retracts into the brain surface. Now, the father of AVM surgery, Professor Yassergil, stressed the importance of the ventricle, especially when you deal with AVMs that have this conic appearance. And for whatever reason, many of these deep feeders in a large number of AVMs that get close to the ventricle, they are actually coming from the ventricle. And it's not that unusual, even though you might not see on the preoperative angiogram, because the angiogram is overwhelmed by the bulk of the AVM. It's not that uncommon that there is a small draining vein along the apex of the deep draining vein along the apex of the AVM. And for whatever reason, these feeders are much easier to deal once you are in the ventricle, that if you try to deal as they go into the AVM through the white matter. So that's another trick. If you are close to the ventricle, quite often it's better to get all the way to the ependymal surface and go down and around that apex, because makes that coagulation of these deep feeders easier in that situation. Now, if as you are disconnected the large feeders, it is possible that the AVM suddenly might change consistency. And I think what happens in some of those cases is that you have disconnected most of the large feeders. There is still some slow drainage. You are manipulating the vein, but you have not taken the main draining vein. But all of a sudden, because of the slow flow, the main draining vein might thrombose, and then all of a sudden the AVMs gets full, becomes much more difficult to retract and to manipulate. And if you still have some deep feeders coming from below, then you might be faced with sudden, otherwise unexplained bleeding. Another important thing to consider is that you're doing your resection, always check and get a sense of the condition of the surrounding parenchyma. If you notice a relatively sudden change, and you get the impression the brain all of a sudden is swelling, then consider the possibility of an intraparenchymal hematoma that can happen usually from retained nidus, as you might have got through parts of the nidus, or even the possibility of intraventricular hemorrhage. And if there is any question, don't do anything, like don't start going through parenchyma, bring the ultrasound and making sure that if there is a hematoma, you are able to clearly identify it. Now, as you go through the resection, as Evandro de Oliveira used to say, is that you get to a point where, like big meningiomas, that all of a sudden they start unfolding after you have done a large intra-tumor debulking. An AVM, a large AVM, all of a sudden you get that feeling that the AVM has surrendered. And the bleeding, you run less often into bleeding from the sides of the AVM. The AVM has become quite easy to mobilize because it's mostly disconnected. It's a nice feeling, but again, never trust an AVM until it's completely out. Now, another thing that some of my mentors were stressing, but I realized how important it was to understand, is that there are often almost like direct feeders that come from underneath the main draining vein. So like in this case, you got the feeling that the AVM is completely surrounded, but you can see after temporary clipping, the draining vein is still red. And the reason is because even though the 99% of the AVM has been disconnected, right under that main draining vein, there are feeders that are coming from below, and almost like they have a direct AV connection. So that's not uncommon. Be wary of that. And therefore, whenever you can, it's important to maximize the chance of complete resection, to skeletonize, if you can, a portion of the main draining vein trunk. And this is particularly important to avoid the residual in children, where often they have the so-called linear type AVM, where it's a venous axis with small feeders going, creating almost direct AV shunts around this main venous axis. So in conclusion, surgery is a process, and the process is made of single basic steps. And when it comes to AVM surgery in particular, but any other procedure, psychology is particularly important, especially for AVMs. Planning a strategy, and I would be lying if I say that I mastered the decision-making process, because there are still several situations where, when faced with the particular AVM, I'm not 100% sure what is the best strategy to pursue in that individual patient. Anatomical knowledge, of course, is key, like most of the things we do intracranially. There are basic microsurgical steps that need to be respected. And then it's a matter of putting together teaching points from mentor, friends, books. I find incredibly useful webinars like this. I log in and I learn every time I am connected. So the more you can learn, the more you can absorb. It's never enough. And experience, and the fact that you have been there before, and the fact that you have been able usually to deal with the same issue over time becomes very, very important. And that all this translates into effective execution. And notice that I don't use perfect execution, because, as I said, with the complex AVMs, at the end, everything goes well, the AVM is out, the patient does well, but the dissection often is not quite as beautiful as it is in the first portion. Thank you again for this invitation, and congratulations for all the work that you have done over the years for the Ibnc, and congratulations, Dr. Avci, for the presidency of the Turkish Neurosurgical Society.
Thank you, Giuseppe. Excellent presentation as always. I agree with you. Joining these webinars, I learn a lot from the audience and sometimes the participants, and a beautiful presentation. So we'll take the questions at the end. And our next presenter is Dr. Michael Lawton from Barrow. He'll be talking about the tricks in microneurosurgery of the brainstem vascular cavernous malformations. Mike, please share your screen.
Thank you, Mustafa. Okay, can you see my title slide now?
Yes, we can see.
Perfect. Okay. Well, thank you for the invitation. Congratulations on a great webinar. I was looking at the participants. It looks like you're just shy of 400. So congratulations for that. So I'm going to talk about surgery for brainstem cavernous malformations. The numbers that I have, these are a little bit out of date, but just shy of 1,000 of these. And of those, you can see close to 300 of these have been in the brainstem. So it's a big experience. I'm in the process of putting together my next book, 7 Cavernomas. There are a couple things that I've been working on this. One is a taxonomy for the approaches. The second is just to talk about all the various tissue-sparing approaches through the subarachnoid space, which are so elegant with these lesions. And then some of the decision-making issues. This was touched upon by Giuseppe, but there is a lot of psychology and cognitive parts of this this particular lesion, just as with AVMs. And so it's interesting to delve into some of these things. The metaphor for this book is maps. And here's a picture of the Marin Headlands. I lived here for 20 years. It's a beautiful place. San Francisco is in the distance there. And the point here is that, you know, if you were just dropped off by helicopter into this landscape and had to get back to San Francisco, it's very easy to get lost and you may not make it to the city. And what really matters is knowing your trails, being able to identify the landmarks that are there in the wild, being able to pick those up and follow them. And those will lead you right to your targets. And I think we've adapted that way of thinking for our cars. This is a screenshot from my Tesla where, you know, from my house, I can map out my course from home to work or from home to a restaurant. And it's gotten to the point where you almost don't even think about pulling out a map or worrying about directions, because it's just such a convenience now that's built into our day-to-day life. Well, I think the same is true with our surgery. And you know, the tenets are these, but the idea is that the arteries really become those trailways, those navigation points that will lead us to our targets. This is a paper that I worked on with Al Roten, the only paper I co-published with him. And he did a nice job of summarizing segmental anatomy of the cerebral arteries. And we just kind of rounded this out so that every point on the vascular tree has an alphanumeric. And if you think about the segmental addresses then for all of these different pieces of the circulation, you can then use that arterial tree to navigate your way to your target. This is just a slide showing that if you really understand your anatomy, every piece of the tree has an address, and you can correlate the target that you're trying to reach with your cavernous malformation with that segmental address of the artery, and use that almost like those red trails on that map to get you to the point. The other thing that I find really interesting and helpful for cavernous malformations is thinking about the anatomy in terms of triangular dissection spaces. And this is just a view looking into the carotid cistern. And when you look at this, you see nerves and vessels and anatomical spaces. But if you think in terms of triangles, then this really directs your thinking as far as where you're going to go to actually get to that point on a peel surface where a malformation comes to that surface. And when you think of these triangles, you really get to planning your routes. So there's the carotid oculomotor triangle, which we all know so well for the basilar apex. There's the oculomotor tentorial triangle, which we use for bypass, and so forth. These are some of these triangles that we spent a lot of time in the lab defining, because what's so useful is they really open up things that you need to get the exposure. This illustration to the left, this is the pre-communicating triangle, so vital for anteriorly projecting ACOMs. There's also the junctional triangle in this corner over here between the A1 and A2 that gets you behind the complex for the superior and posteriorly projecting ACOMs. These are these three triangles for aneurysms in and around the carotid cistern. The bypass triangle over here is the oculomotor tentorial triangle, which is so nice because you can get to the P2 segment or the S2 segment of the superior cerebellar artery. These are triangles in the posterior circulation. The vago accessory triangle is invaluable for pica aneurysms, and it subdivides into the infra and suprahypoglossal triangles. If we keep going, glossopharyngeal cochlear triangle, very common triangle, particularly for tumor pathologies and for these high-riding pica aneurysms. And then on and on. There really literally are triangles everywhere you look in the anterior cranial fossa, posterior cranial fossa, middle cranial fossa. And these triangles are useful ways to think about roots. Now, once you get there finally to the brainstem, you're staring at surfaces, and so the surface exposure and surface anatomy becomes critical. These are just some illustrations showing what different approaches will give you. But it's really all about the surface anatomy that you spot, because sometimes these lesions aren't directly on the surface, they're not exophytic, or sometimes not even presenting to a surface. You might only get a tiny blush or stain. And so it's important to understand where your entry zones are, the so-called safe entry zones. And this is just a slide that summarizes some of the major ones. Now, as far as the decision-making, this was published by my group about 5 years ago now. But I think having a grading system for brainstem cavernous malformations has been helpful, because like with AVMs, we encounter so many different varieties, and it's helpful to have some kind of a rule of thumb to walk you through the decision-making and check your instinct. So we identified 5 variables: size, crossing the midpoint, the DVA, the age, and the hemorrhage, and assigned points in a way that's very much like we do for AVM grading. If you think about supplemental AVM grading, which is now 6 different variables, it's Spetzler-Martin, size, eloquence, venous drainage, but also age, bleeding, and compactness. It's very analogous here. You've got size, a developmental venous anomaly, that's like your deep venous drainage. And crossing the axial midpoint was really our kind of nod to eloquence. And the more that the lesions are in the midline, the more they're right in the core of the circuitry of the brainstem. So there's your eloquence, just even though everything in the brainstem is eloquent. The age, similar cutoffs, except we just have a 0 and a 2 rather than 3 different grades or criterion. And then finally, hemorrhage. You know, the timing of the surgery is so critical with this pathology, because as you wait and these lesions scar in and the blood from an acute hemorrhage disappears, you lose that separability from the brainstem, which affects your outcome. So this is how I like to think about the early decision-making. I like to get a handle on the grade. This grading differentiates brainstem cavernomas into low, intermediate, and high grade cavernomas. The high grades are the 6s and the 7s, and those are the ones to be particularly cautious with. Everything else is fair game, but obviously there's a graded difference. This is the initial paper that we published with very few high-grade patients, 6s and 7s, but with time and experience, you can see that we've gathered a bigger experience here, and the outcome actually is very well predicted by the grade. Whether you look at good or poor outcomes, absolute outcomes, or whether you look at relative outcomes, worsening or improved or same, the grade is really helpful. And it's those 6s and 7s where you can expect poor outcomes or greater frequency of worsening. And so that really is helpful in the selection criteria. These are the areas under the ROC curve for those who are statistically minded, but it really is has proven to be a valuable tool to make these decisions. So I'm going to go through some of these approaches. I like to think of the corridors of surgical exposure. They're listed here. And these are the 7 cavernomas, the different areas where we go after these. And I'm going to just confine my talk from the rest of the way here to the brainstem, midbrain down to medulla, and walk you through some of these approaches and show you some videos. So this one is really midbrain and thalamic. If you look at the presentation, this woman presented with a homonymous hemianopsia. Her grade was a 3, so she's an intermediate grade, well within what we would take on. The approach here is going to be the contralateral supracerebellar transtentorial. So this is one that I'm sure Professor Toure will enjoy. You can see here, it's sitting in a tough spot. It really is rising from the midbrain up into the thalamus primarily. And there really isn't a peeled surface that this comes to, except for one small point. If you look in this little corner right here, at the very back medial corner, there's one point where this comes to the surface, and that really is the spot that you want to try to get to. So we use our segmental addresses. This is right along the P3 segment of the posterior cerebral artery. We use all of our surgical tricks for this, and for that, I mean, we're going to do a contralateral exposure. So to get far enough lateral to reach this thing, you want to start over on the left side and go cross court over to the right. And that gives you an additional reach laterally to get into this particular space. If you just try and stay ipsilateral, you get confined. And you get confined by the tentorium. You have to cut the tentorium, and you don't get the angles that you need to have that trajectory. So here's how it looks. It's sitting position. The approach starts on the outside, on the contralateral side, crosses midline, goes across, and we do need to cut the tent because, again, we're reaching upwards into the thalamus. The sitting position and gravity retraction gets that cerebellum moving down out of the way. We do need to cut the tent to get that extra reach, and you can see our triangular space here is between basal vein of Rosenthal and the vein of Galen. So here's the video. This is just showing you the patient position. It's a sitting position, a little head tilt, midline skin incision. There's the craniotomy. It's a torcular craniotomy because we want to get as high under the tentorium as possible. And there is that incision in the tent. So here now is the video. One of the first moves is to release CSF from cisterna magna. That sags the cerebellum nicely. And now we can open up this supracerebellar plane. And here you can see I'm right in the midline, and you see how far off I am from the lesion. So continuing on, we've got to start getting that contralateral lateral trajectory. So there's our trail map here. This is the PCA, the P3 segments. We're going to follow that P3 segment proximally. You can see a little edge of the occipital lobe, and you can see we're going from quadrigeminal to ambient cistern here. And as we follow that basal vein out, you can see we're limited by the tentorium. The tentorium keeps us from getting further laterally, but with a little relaxing incision, we can then start to shift the angle. You see now how this starts on one side. Let me go back to that. We start on one side, we cross the midline and go to the contralateral side, and that puts us in direct line with that lesion. So this is the advantage of this contralateral exposure. We can then follow the PCA more proximally. We're beginning to see some stain, and here's that point that we were talking about, right at the under surface of the malformation. And so a little opening here in the pia on that pulvinar surface of the thalamus gets us right into the clot, and we've hit our target directly. So the rest of this is just freeing the malformation, piecemeal debulking, and working the plane of separation around this thing. And here you can see it coming out in pieces. At the end, what we're looking for is that clean cavity. There's the big piece right there. After working the plane, this thing should separate nicely. I like to try and keep it as intact as I can, but here's what we want. We want that clean gliotic surface, no evidence of residual malformation, just normal tissue, no extension into that tissue, but just pulling everything inward. And here you can see that vector is all the way at the back end. You can see how gravity has opened this plane for us, and we get this clear inline view with no fixed retraction. So that's the approach, and you can see the postoperative view here, a nice removal with no tissue violation other than just that thin layer on the back end. Now here's another. This lesion is not all that different in terms of its location, but millimeters make a huge difference. So this one presented with hemiparesis, third nerve palsy, upgaze palsy. Again, it's midbrain and thalamus. Same grade. It's a 1 for size, 2 for age. But this one, we're going to go a completely different approach. We're going to go contralateral, transcallosal, transchoroidal fissure. And here's just a diagram showing this one. There are, again, multiple routes to this. You can go transchoroidal fissure. You can go subchoroidal. It just depends on how the malformation relates to the fornix and the superior surface of the thalamus. But here you can see very nicely, this is a little bit more medial, a little bit higher in the thalamus. And the best approach, in my view, for this is to take advantage of the midline presentation here. This one actually does come to the ependymal surface, and this is a great way to access this. So here now is the view. You're looking down the interhemispheric fissure, nose to your right, back of the head to your left. We're in the ventricle now. You can see choroid plexus and foramen of Monroe. The fornix is here, running on the top of your screen. Septal vein is here. This is the thalamostriate curving around the venous angle into the internal cerebral vein. And we open the choroidal fissure here by dividing the septal vein and following the venous angle into the velum interpositum. So what that does is it takes this very small foramen of Monroe and it doubles it in size. So we simply open the choroidal fissure, we get into this velum interpositum, and that takes us now to the surface of the thalamus where the malformation comes right there. So here you can see the malformation. It's worked its way to the ependyma. We've got a great shot at this, and we can start doing our resection. So here's the view. Again, long corridor, deep reach, but we can start to mobilize this thing out of the thalamus by pulling it downwards, away from the eloquent tissues and into the third ventricle. We can work that plane, and I'll just expedite this here. You can just see, once you work the plane, pieces now start to come out. Again, try to keep the capsule intact. And at the end of the day, after things have been worked, we again start to see that clean gliotic surface that we're looking for, that indicates that this thing is all fully removed. So here is just a nice little anatomical tour. This is the top of the basilar artery after doing a third ventriculostomy. You can see a view downward onto the trunk there and the thalamoperforates. And here just inspecting the capsule. And here's that overview showing how the transchoroidal fissure widened our foramen of Monroe dramatically, gives us a view into the ventricle, gives us a view into the third ventricle, and we can really do a lot with that. Here's the post-op. You can see a nice complete resection. So next one, this is a midbrain lesion. This is, I'm going to show you the lateral supracerebellar transtentorial approach. This was a low grade, one for size, one for the bleeding. And here are the images. This one, if you study this one comes to that posterolateral tegmental surface here. So this is a midbrain tegmental malformation. The best view or best trajectory is going to be through that surface there. And when you look at this one here, what you see is it actually rises quite high. It's not purely midbrain, it goes up into the thalamus. So that's what makes this, or calls for not just a supracerebellar infratentorial approach, but a supracerebellar transtentorial approach. And this, in fact, was a redo. So you'll see that in the video. But anyway, this is the lateral view of the exposure. You're going again over the cerebellum. I like the sitting position for this. Again, it's working under the basal vein of Rosenthal. We're going to cut the tent on this one. And here is the video. So here is that view, patient sitting, tentorium is here, the cerebellum sags nicely. And as we open up this supracerebellar plane, we release all of these arachnoidal adhesions. We're now arriving at the ambient cistern. We open up the beautiful arachnoid of that cistern and we get into that perimesencephalic cistern here. We can find the superior cerebellar artery. So this is our segmental anatomy, once again, taking us there. This is the S3 segment. The trochlear nerve here is seen being released along its arachnoidal plane here. And we drop the nerve and go just above that. You can begin to see the malformation here under the edge of the tent, but it's not enough. This was so high riding that we need this tentorial exposure. This is our little relaxing incision all the way to the incisura. Having dropped the nerve, I know that I'm safe in cutting that. And now you'll see that by enlarging that window ever so slightly, we can now increase our trajectory up north. We can see the malformation here coming to that ependymal surface. We see these circumflex perforators going around the midbrain, but we've got a clear shot right through this exophytic portion of the malformation. And look at that view. Gravity is helping us. Our tentorial incision is helping us. It's a little awkward for me because I'm sitting and I'm raising my arms and hands, but you can see that it's a clear shot. And now we start the work. Here's just the navigation views showing how that's a nice direct trajectory. And I'll just jump to the end here. We do our usual thing, freeing up all of those planes, pulling out this in as few of pieces as possible, and ultimately cleaning that cavity. So here are some of the final pieces. And again, it's all about keyhole surgery. You're making a big surgical approach with your craniotomy, but in the end, you get to an internal keyhole and you've got to work that plane and get every last bit of that until you see that nice, clean gliotic surface there. So there's the post-op showing a nice, clean resection and a good result. Now, in the interest of time, I'm going to just, I think, jump ahead and show you this case. This is in the pons. Patient presented with left facial numbness, had a lateral pontine cavernous malformation. We do the grading. This is basically a grade 3. So again, intermediate grade, good surgical candidate. This will be an extended retrosigmoid approach and a transmittal cerebellar peduncle approach. And this is a great case because it just shows you how this safe entry zone concept is so important. You look at this malformation, it's completely surrounded. It doesn't come to any surface. If you, no matter what approach you choose, if you get to the PL surface and inspect it, you're not going to see hemosiderin, you're not going to see malformation. So you do have to do an entry here. And this safe entry zone here on the middle cerebellar peduncle has proven to be a real workhorse and a truly safe entry zone. The key is the craniotomy. You need this, what I call extended retrosig. It's not enough to do the tick operation, which is just a small opening back here. You've got to skeletonize the sigmoid. You have to really be flush against that petrous face. And the only way you do that is sort of an ENT style approach to the exposure. And what that opening does is allows you to go from this kind of view, which we get with the tick operation, looking along the petrous face down at the nerves as they cross the cisternal segment, and shift it so that you're actually going through the middle cerebellar peduncle with a different angle. You see, we've gained about 30 degrees of rotation here by shifting that angle. And one of the things that you've got to do is you've got to split the petrosal fissure here. And that's this fissure here that runs from the CP angle along and between the superior and inferior lobules and intersects with the flocculus. And by opening that petrosal fissure, like what you see here, you bring this lateral portion of the peduncle into view. Technically, that's not brainstem, but by going through that portion of the peduncle, you get to the lateral brainstem. And that's exactly what you'll see in this case. So here is the sigmoid sinus, transverse is up here. So as we go intradural, this is petrous face, tentorium is up here, and this is the petrosal fissure. You know, I call this the Sylvian fissure of the posterior fossa because by splitting this fissure and following the branches of the ICA down, just as we do the MCA, we open up this space, we expose the DVA. This is the DVA here coming into view. It's this massive vein here, but we can get to our ICA branches. We can move the DVA off of the peduncle, and we can see the lower cranial nerves. This is 5 over here. Proximal branches of ICA are over here. Our DVA is completely free. And you can see that here's our angle. We're missing the malformation. We've got to spin this a little bit even still. And so I'm going to go back and split a little bit more fissure here. So this is even more lateral in the fissure following these more distal ICA branches. And what you'll see is that as I split that, I get to the lateralmost part of the peduncle, which is right there. And you can see I don't even view the lower cranial nerves anymore because I've made that spin on the trajectory. I'm now aimed right at the malformation. I've got my target in the crosshairs, and now we can make that parenchymal dive. So here we're finally going into the middle cerebellar peduncle. Here's a little fimbria of the venous malformation, which is okay to go through as long as you preserve the trunk. And now as we get past that, you can see the malformation finally. It's about 1 centimeter of tissue in the middle cerebellar peduncle, and we hit the capsule here, and you can see liquefied blood coming out. This is a great example of how timing can help. If you time the surgery to be in that subacute phase or late acute phase, this blood liquefies. You can create working space within that cavity, and it just facilitates the resection. So again, working the planes here, using these really nice round knife instruments to free the adhesions, and then ultimately this thing comes out. And this is an example of how if you work that plane very expertly, it'll come out as a single piece. And the beauty of a single piece resection is that you know you've gotten it all. There's not going to be a piece that or fragment that you've left in a blind corner. You know that it's all out. And so again, here's our check at the end. We're all the way through the cavity. We're at that lateral pontine surface, and we've done it through this transparenchymal safe entry zone style approach. Preservation of the DVA, entry lateral to all of the cranial nerves, and this was a high functioning CEO of a corporation, and she did beautifully. So this is just your anatomical tour. Always good to savor the anatomy here at the end. Anyway, here's her post-op view. You can see that trajectory, how lateral we are in the peduncle. We're avoiding all of the descending motor pathways. We're avoiding all of the cranial nerve nuclei. And she did very well in this. So I could keep going. I mean, I have so many of these beautiful cases that I'd love to show you, but I'm going to finish by just kind of summarizing. The challenge cognitively for us is in the decision making and in the approach selection. So it's patient selection and approach selection. And for midbrain, you know, you've got a lot of options here. This is a menu that just shows you some of the different surgical options that are available. I only showed you some of these. I showed you the transcallosal transchoroidal fissure, and I showed you the lateral supracerebellar approach. But these are two of many. You have other options here, but these four that I put the check mark on are the workhorses. For the pons, same story. There are a lot of different approaches, different craniotomies. The workhorses are the retrosigmoid, either through the cerebellopontine angle, this cistern, or through the MCP. Or you can go suboccipitally transventricular if it comes to the fourth ventricular surface, or you can go through a transpontomedullary sulcus approach. This is another one of my workhorses, which I love. But these are the four that I use most frequently for pontine lesions. And finally, medulla. The medulla is a lot shorter list. You've got basically either a transventricular or T-lobular approach, or far lateral if it comes to that surface extraventricularly. So to wrap it up, trying to stay on time here, patient selection is the secret. I look for candidates with hemorrhage and deficits, and I find that the grading system is helpful. You don't need a grading system for all cavernous malformations. What you need a grading system for is the brainstem ones, where that decision-making is very, very difficult sometimes. You're looking for lesions that come to the surface, either pia or ependema. Again, approach selection and really knowing your safe entry zones is critical. We talked a little bit about this whole intracapsular dissection technique and en-bloc resection. I think that's a valuable lesson to learn.
Clinic is committed
And then
to
finally,
creating a safe environment
there's a
for
really
our
fine
patients
line between
and staff
pushing too
to
far,
ensure everyone's
trying to
safe.
get a complete resection, and not pushing hard enough and leaving a piece behind. You have to walk that fine line. It's not comfortable on either side. You don't want to push too far and have deficits, but you don't want to have malformation that remains and have to either take the patient back or be faced with a recurrent hemorrhage down the line. So it's a real fine line, and I think it's what makes this surgery so challenging. So I'm going to stop, and I'll stop my share. And again, thank you all for having me.
Thank you, Mike. Excellent as always. And you want to take the questions now or at the end?
Yeah, I'd like to do it now just because I'm going to have to run out in about a half hour.
Sure. So we have two questions from the audience. Dr. Mehdi Kalegi is asking you, do you usually put take-up sutures for the tentorium when you cut the tentorium?
I don't. I find it awkward to sew in that tight space. We just published a paper this year in JNS, and the paper talks about the what I call the Hernus-Nemi technique. You know, Juha, when he cuts the tent for a subtemporal approach to a basilar, he introduced that idea of using an aneurysm clip, making a second little nick in the dura and tacking it with a clip to the side. We do the same for the tentorium on a transtentorial approach. You can make a little nick in the tentorium. You can use an aneurysm clip to hold that folded edge of the tentorium over. And that's a really nice, slick trick to use.
Correct. I don't suture either. Sometimes I resect the small amount of the tentorium. I think Evandro published the wider resection of the tentorium, but that's too much to me. I'll cut a little bit. And then other, Dr. Elshan.
If you take too much tentorium out, the brain will sag into your field. Correct. And you want to make sure that that tentorium is really functioning like a retractor. And if you resect too much of it, it falls in. It's the same that we get with the Falks. If you're doing one of these gravity-assisted interhemispheric approaches, resecting the Falks creates a nice window, but if you take too much, the brain will sag in and take away that window that you create.
Correct. And Dr. Elshan Hüseinzadeh is asking, do we need to always preserve developmental venous anomaly? And is some correlation between DVA and cavernous malformation recurrence?
Yeah, it's a great question. The early, for those of us who have gray hair, back in the day, people were thinking that cavernous malformations were a result of venous hypertension and some flow aberration in the developmental venous anomaly. So it was pathogenetic, but at the same time, we were told dogmatically that you had to preserve the DVA, otherwise you'd get venous infarctions. I think the latter is very true. You can get complications if you don't preserve the DVA. I think the former is not. We've learned that the pathogenesis is really more a genetic problem, not a hemodynamic problem. So I think leaving DVA is essential for the hemodynamics, and it doesn't affect the recurrences. So I have doubted that theory, and I can remember two very vivid cases where I couldn't save the DVA. It was a Vermean cavernous malformation, and it was a precentral cerebellar vein, and I didn't think there was anything wrong with just taking it, because I had a real hard time saving it, and the patient had a venous infarction in her midline cerebellum. So I learned my lesson the hard way. I think the DVAs are important. One thing that is important to say, though, is I think of the caput medusa as a trunk, which is my wrist, and then the fingers, which is the caput. It's okay to truncate some of the fingers because sometimes those are really intimate with the malformation, but you got to save the trunk. Like that last case I showed you, that trunk in the CP angle was enormous, and you got to save something of that magnitude. But the little fimbria or the little fingers, I think you can take.
Yeah, I do the same, especially when you do supracerebellar infratemporal approach. I like to preserve the precentral cerebellar vein, although textbooks say you can take it. I didn't preserve like you one time. I had a venous infarct. If you need to take, you just take the couple of tributaries, minute tributaries, but not the main vein. And we have one last question. Dr. Najjar is asking, is it safe always to coagulate supracerebellar veins, bridging veins? I believe he means. So
yeah,
what's your take on that?
Yeah, I think he probably saw that in my video, and
correct.
I think when I was a resident, everyone told me, yeah, those are fine, those are fair game, and so I never really hesitated, and I think my experience over a couple of decades now has borne that out. Those bridging tentorial veins from the superior cerebellar surface, I think, are fine to take, and in fact, if you don't take them and the cerebellum starts to sag and you're working in that plane, what happens is you avulse them. And then you've got a bleeding lake from the tentorium that's often a real challenge to control it. So those are fine. And I haven't had trouble with that.
Thank you, Mike. I mean, it's also the judgment call when you expose the tentorial surface of the cerebellum is small veins you may take about, but this is sometimes you can have very dominant veins, and you try to preserve as much as you can. So we thank Dr. Lawton. Oh, there are more questions. Sorry, it's there. They keep coming. Mike, do you operate on patients who present with their first hemorrhage but remain fairly neurologically intact and or functional with minimal deficits?
Yeah, that's a great question. It's always bothered me that people have this idea that you have to wait for a second hemorrhage. The thinking is logical. Like if a patient has a hemorrhage and they're neurologically normal, why operate when you're only risking making them worse? But at the same time, if you don't operate and they bleed, they could be devastated by that, particularly if you're talking about a brainstem cavernous malformation. So I kind of have come to reject that thinking, and I offer patients surgery if I feel like I can keep the operative morbidity in an acceptable risk range. So like after a first hemorrhage, if a patient comes to me and I know that I've got the right approach, and I know that the patient's young and has a high likelihood of repeat hemorrhage, I'll offer it. They don't necessarily want that. They may want to wait for the second hemorrhage, but there are, I think, a fair number that are concerned about the natural history and want to be proactive. And I frankly think that that's an acceptable way to manage them.
I agree. And then also regarding the timing, I completely agree with you. Early, so in your grading, you mentioned the timing of the surgery from the first bleed, 0 to 3 weeks, and about 3 weeks. Is within that time is much easier to operate because the hematoma liquefies and then makes your dissection planes easier. On the contrary, if you operate late, sometimes you have to, patient comes late, nothing you can do, but that fibrotic blood clot makes everything harder. And there's also certain conditions that you have to do emergency surgeries. And we publish our experience in few patients like that, emergently taking, patient has no respiration, fixed dilated pupils, and it can be very rewarding in some of these cases doing the emergently. So
one comment I'd like to make on that. I totally agree. That's why we put that variable into the grade. There is a little subtle nuance, though, that I think is important. If you look at the timing that gets 0 points, it's 0 to 3 weeks. And there's a huge difference between operating at like 1 or 2 days after a hemorrhage and operating at like 2 weeks to 3 weeks afterwards. Like 2 to 3 weeks afterwards, still within that acute phase, is fantastic because the hematoma is liquefied. It comes right out with simple suction, and you've got a working space. But if you're operating at 24 hours or 48 hours, the hematoma isn't liquid yet. It's actually very thick. The cavernous malformation can get lost within that thick gelatinous clot, and it can actually be harder in the very earliest portions of that window to do the surgery. So even though the grading scale is what it is, we didn't know how to separate that out. You have to be aware of that little nuance.
Correct. It's that's what I meant actually. It's around 2-3 weeks time that Dr. Hiros used to say the same thing when I was training with him. And unless it's really emergency, sometimes you have to decompress the hematoma. And Dr. Adnan Kasım is asking, what was the most common complication you faced after cavernous malformation surgery in your case series?
Oh boy, that's an impossible question to answer. These things touch cranial nerve nuclei. They touch critical tracts, descending and ascending, and everyone touches each one of those a little differently. So the fact is that when you take them out, you're going to tweak those things. You're going to get some temporary worsening of either a cranial nerve function or a tract function, and you get your deficits post-operatively depending on not only where they touch, but also the timing, like we've been talking about, or your technique. If you're overly aggressive, if you pull too hard or don't free the adhesions before you start to remove the pathology, you can really hurt these patients. And I think Dr. Spetzler was very honest with his publications on the matter. He had a 40% rate of neurologic worsening perioperatively, and that's a significant number. Fortunately, most of that, in my experience, is transient. But I think the complications that you're asking about are just neurologic worsening that relates to how close these things are to extremely eloquent tissue. And you just have to be so gentle with them and work those planes so carefully.
Thank you, Mike. A couple of more questions. One question is already answered about the bridging veins and temporal surface, and Dr. Iberg is asking, are these cavernous malformation dynamic lesions? Does it make big difference in their size? So is a bigger the cavernoma, more dynamic?
Yeah, we're finishing a paper on just that topic, and you'll see it in hopefully soon. But anyway, we looked at cavernous malformation size in some of those that we followed, and there is some dynamic nature. And as we all know, these things look like a clump of like a mulberry, and then they bleed, and they've got this enormous additional piece that's hematoma. So they do fluctuate. They go up in size. They go back down to their size when they were just pure malformation, and so there is fluctuation. But the trend is generally one that sort of increases over time. I think as they bleed and these little hemorrhagic areas kind of wall themselves off, you generally have a progressive enlargement. It's not typical that they shrink. So that there is a dynamic character to that for sure. So that variable in the grading system will change.
Thank you, Mike. And then is there an age limit for sitting position? What is the youngest age you use? Dr. Kumar is wondering.
Oh, well, on the young side, I don't worry. Young is easy. You know,
True.
I think we did a sitting position last month in a 3-year-old. But where age becomes a problem is old on the other end. And when you're talking about doing a torcular craniotomy in an 80-year-old with adherent dura and the potential of shredding the torcula, that's a huge concern. So I actually worry on the other end. And if that's the case, you know, Ugur probably has done more of these than me, but what I do is I will do, instead of a torcular crani, I'll do a suboccipital up to the sinus, and then just drill that edge up to the inferior edge of the transverse sinuses. And that avoids my having to cross an elderly torcula, and that's a way around it.
Correct. That's what I do the same. Do you always take hemosiderin part of the, you take the cavernoma, but do you remove also hemosiderin staining, or just the cavernous malformation of the brainstem?
Just the cavernous malformation. In the brainstem, you don't have that luxury. Absolutely not. Every cell is valuable, and you have that luxury in the cerebrum in some portions, and I only do that there when there's a seizure problem. You know, if it's in a non-eloquent area, patient has a seizure history like intractable seizures, then I'll take a little hemosiderin ring, but absolutely not down here in the brainstem.
Correct, 100% agree. Thank you, Mike. I think that's all we have. And thank you again for your contribution, and always enjoy your talks. So we are not going to hold you here. Have a good Saturday and Sunday. Have a good weekend.
Okay, thank you. Thank you all.
Bye-bye. So our next speaker is Professor Uğur Türe from Yeditepe University, Istanbul. He will be talking about the microsurgical tricks in dealing with the mesial temporal lesions. Professor Türe, please start sharing.
Just 1 second. So can you see my slides?
Yes, I can.
Okay. So thank you very much for such a great invitation. I am very happy to be with you with such a distinguished faculty. I would like to thank and congratulate our president, Dr. Avcı, and it is great honor to celebrate her presidency here. And she just elected last month, and I believe that she will go forward and improve the quality of Turkish Neurosurgical Society. And I thank again for kind invitation, and also Dr. Emmes for excellent organization. My talk about the tricks in microsurgical treatment of mediobasal temporal region lesions. First of all, I like to stress the term of mediobasal instead of mesial. I think this is wrong terminology, and which is very common. Mesial means the inner side of the teeth. There is no other meaning of mesial. So we have to call it mediobasal. I think this is an important point that I like to stress. And what is mediobasal temporal region? Mediobasal temporal region is the one of the part of the limbic system. And this picture from Professor Yaşargil summarizes what is neocortex, what is mesocortex, and what is allocortex. And this is beautiful picture. And very important to look the coronal picture, which I learned from him. Always we have to look the coronal picture. Axial picture in the cerebrum is, you have to look in the as a third picture. First coronal, and then sagittal, and then axial picture, because axial picture can confuse. You have to get the exact orientation, and you have to find the exact location of the lesion, which is the coronal picture is helping us. So mediobasal temporal region is here, the part of limbic system, which is it includes a mesocortical structure such as parahippocampal gyrus, and then allocortical structure such as hippocampal formation. And why I call this my topic as a mediobasal temporal region lesions, because especially the gliomas of mediobasal temporal region stay in mediobasal temporal region. They don't go easily to neocortex. They can extend to the insula, or they can extend to the temporal pole or mediobasal temporal region, but they are in the same system. They are in the limbic system. So the limbic system tumors stay in the limbic system. And if we understand the exact location of the lesion in the mediobasal temporal region, we can plan our surgical strategy. Here is the mediobasal temporal region, and which includes the uncus temporal pole, also includes the which is part of paralimbic system, which the mediobasal temporal region tumors mostly extends the temporal pole also. And then in the posterior part, they can go up to the isthmus or goes to the lingual gyrus. But the mediobasal temporal region gliomas never extend to the lingual gyrus. This is also another story. Anyway, the surgical approach to mediobasal temporal region is tricky. And there are, mediobasal temporal region is not eloquent area, so-called eloquent area, but the location is most eloquent area, because you can damage many structures. You have to deal with the very important neural structures and very important vascular structures, and it can be disaster to approach to mediobasal temporal region, which is very important point, I think. This is very long structure, and it starts from piriform cortex, and it goes back to the isthmus and lingual gyrus connection. So there are 3 portions, and each portion of mediobasal temporal region needs another surgical strategy, which I am trying to summarize my philosophy about these surgical approaches. There are many surgical approaches described for the mediobasal temporal region. This is one of the reasons because this is very long structure that you cannot get all portions of this structure in one surgery. And another reason is also to get that portion is not easy. But my philosophy to get the mediobasal temporal region is we have to preserve the normal structures. That's the point. So if you go through the temporal lobe, you can get everywhere. But this temporal lobe is valuable structure, dominant or non-dominant hemispheres. We have many structures, many white matter fibers within this white matter. So we have to preserve them, except alveus, fimbria, fornix, and cingulum, which these are the part of mediobasal temporal region, which is our surgical target. Just we have to summarize. If we go through the neocortical temporal, transsulcal or transgyral, doesn't matter. You know, within the depth of the sulcus, there is cortex also. And here there is cortex also. So it doesn't matter, you have to cut U fibers. And then you have to cut the inferior arm of superior longitudinal fasciculus. And uncinate fasciculus is in very danger in the anterior part. And occipitofrontal fasciculus is, you have to cut it. And anterior commissure, most of the fibers of anterior commissure joins the sagittal stratum. And if you go laterally, you have to cut them. And then sublenticular portion of the internal capsule, temporopontine and occipitopontine fibers. They are running in the roof of the temporal hole. And then inferior thalamic peduncle, and as well as posterior thalamic peduncle. This is not pure optic radiation, as I try to focus this, and optic radiation is part of the posterior thalamic peduncle. And also the auditory radiation is part of posterior thalamic peduncle. And then tapetum is another structure just in the roof of the temporal horn. So our surgical strategy always has to, we have to keep in our mind that we have to preserve these fibers. And then also as well as inferior longitudinal fasciculus. But the alveus, fimbria, and fornix, these are belongs to mediobasal temporal region. And then of course the inferior arm of the cingulum. So these are the part of mediobasal temporal region. So I approach mediobasal temporal region very simple way. Most of them I use Yashargi's Transsylvian, paternal Transsylvian approach. And then last 12, 14 years, I use supracerebellar approach. So I would like to discuss with you how I choose the cases for which approach. So this is very typical. So left is left always in my axial pictures and coronal. And this is a left-sided piriform cortex tumor. So what is piriform cortex? Piriform cortex is the mostly part of uncus, what we call uncus, and also semilunar gyrus and ambient gyrus. So this is a typical piriform cortex tumor, and this is typical cause of the limbic seizures. And the key in this case, it looks easy, but when you look in the medial side, this is amygdala, so the optic tract is that just touching the tumor. So in this case, we have to be careful to preserve the optic tract, not only itself, also the vascularization of the optic tract, which is the anterior choroidal artery is one of the main point. And then also we can preserve so-called temporal stem, which is another story. But we have to preserve all fibers, doesn't matter, temporal stem, frontal stem, whatever. You can call whatever, but we have to preserve normal structures, normal white matters. That's the point. And this is the key, is the Transsylvian transamygdalar approach. After opening of Sylvian fissure, we can go directly to piriform cortex. And then when we go to piriform cortex, we can remove the tumor, and we have to be careful in this part that optic tract is touching the tumor. The main important point is this. So orientation is very important. We have to see the cisternal anatomy, and then we can remove the tumor. How much posterior? Depends on the cases. You know, if there is a big tumor extends posteriorly, I can still use the Transsylvian approach. But if the tumor is only anterior located, to get posterior is difficult. without damaging the white matters. So this is left-sided Transylvian approach. This is after opening Sylvian fissure. This is the key point, and to see the M1 and anterior choroidal. And then this is after resection without retraction, it's possible to remove. And this is just showing that selective removal of the preformed cortex and with preserving of optic tract, which is just in the medial border of the tumor, and preserving this temporal stem, which confirmed with the tractography. I use tractography pre- and post-operatively routinely, and this is important. U fibers, uncinate fasciculus and fronto-occipital fasciculus, after removal, is possible to preserve, and of course the optic visual field. It was the NET. Another case, very similar, again, right-sided. This is right-sided preformed cortex, but it's more hippocampus is involved. So the same approach, right-sided approach, but more extensive resection, including head of hippocampus, but still preserving this normal white matter anatomy, which is, we can demonstrate it. You see, uncinate fasciculus and fronto-occipital fasciculus is intact after resection. And this is visual field. And how the temporal, mediobasal temporal anterior tumor can extend. This is one of the points. But still, this is not crazy tumor. The tumor stays in the mediobasal temporal region, extends to temporal pole, which is also limbic system, and extend caudal orbitofrontal. But this is a little tricky case. That's the reality. And many people, not many, general understanding is the tumor use the uncinate fasciculus and go everywhere. Please note this. Gliomas are not following fiber tracts. This is against what general believe, but you will see one day that it will confirm. And when you look at this picture, it looks like no uncinate fasciculus, no fronto-occipital, or tumor destroyed and goes everywhere. No. Uncinate fasciculus and fronto-occipital fasciculus are intact, pushed by the tumor. Tumor stays in the mesocortical and allocortical stem, but the tumor did not destroy the white matter tracts easily. But we can destroy easily in such a case. So this is after removal, just tumor removal. And you can see here that after such a large tumor, again, you can preserve the uncinate fasciculus and fronto-occipital fasciculus, so-called temporal stem. Some people are attacking temporal stem and this kind of thing. So I like to put this picture. So this also, this is the possible with the Transylvian approach. But what about this case? This case, tumor starts from piriform cortex and extends to the isthmus. So in this such a case, Transylvian approach is not enough for me. So we can do 2 session surgery, 1 session to get anterior part, and then the second session, posterior interhemispheric approach. But tumor, you see, stay in the mediobasal temporal region. And the collateral sulcus is most cases just limit. And the medial limit is always choroidal fissure. And the superior limit is the temporal horn. So the anatomy is there in any crazy case. So just to change the angle to thinking how we can remove this. So we have to change sometimes to our looking angle to understand better. And then this is Professor Yaşargil described to remove the posterior parahippocampal cavernoma using supracerebellar transtentorial approach. And with his suggestion, I work on this and try to get the everything from mediobasal temporal region using this approach, because from anterior, we cannot get here in one session, but if we come from posterior, we may get the entire length of the mediobasal temporal region. And the problem is, you know, when you go from posterior, it could be difficult to get anterior part. So, because it's sitting in the middle fossa. I work in the cadaver lab in Little Rock, Dr. El-Mefdi's lab, and study this anatomy and how we can remove it. And this is, you see, if you cut entire tentorium, this is your exposure. So in the cadaver also, I simulate the surgery in the right side, and I find that it's possible to remove. And this is right-sided colliculus, fourth nerve, and the roof of the temporal horn. Anyway, and I didn't publish this experience because I would like to wait for surgery. I had to do one surgery. In cadaver, you may do it, but in the reality, maybe you cannot do it. And during that time, Dr. Yonekawa published this paper, but he published again what Yaşargil described, that he used this approach for posterior temporomedial structures. As you know, that Professor Yonekawa was a great surgeon, and he was a resident of Professor Yaşargil also, and fellow. And Professor Oliveira also used the same approach for posterior mediobasal temporal region. But my goal was going anterior to get the amygdala and entire length of the mediobasal temporal region, and which is possible, was possible after 10 years. I wait 10 years for this approach. And I use semi-sitting position, but it is 25 degrees semi-sitting. It is almost supine position, and I use paramedian incision. And very important that we have to use transesophageal cardiography to check any single air bubble. And very important point that I use classic without autofocus, without zoom microscope, because it's short and I can work many hours with this length. And semi-sitting position is excellent for this approach because of the gravity. You know, Dr. Lawton also mentioned that I'm happy that Dr. Lawton, I love to listen to him because he also talked about the semi-sitting position and the advantage of semi-sitting position. And also Dr. Lanzino also is a great experience with the semi-sitting position. And I performed this approach in lateral position when the patient had a cardiac septal defect. It's possible, but it's not like a semi-sitting position. I strongly recommend it. And this is right-sided craniotomy. After reflecting the tentorium, I never cut the tentorium. I just had a flap and tried to preserve the tentorial veins. And then this is after resection, and this is endoscopic picture to get, this is atrium and choroid plexus. And it was possible to remove entire tumor in one session. This is internal carotid artery, anterior choroidal artery, posterior communicating third nerve. And it was very anatomic surgery, and it looks like crazy to go amygdala, but this is my position when I removed the amygdala. Amygdala is the easiest part of surgery. Difficult part is the middle fossa part, lower part, which I need endoscope to use in this case, in this situation. And this is the end of surgery. Right-sided, you see preform cortex to isthmus and remove in one session without disturbing fusiform gyrus or any other structures, and also the so-called temporal stem, which is I never touched them. It was they are in the upper part, so there is no need to show it even. This was my first case, and then I had many cases now, and this is also a typical case, posterior parahippocampal lesion with the seizures, and this is, there is no other way to go, in my opinion. This is supracerebellar approach, and you can get temporal pole also, because also removal of temporal pole also is the part, because it's just in your way. So, and you can go whatever you posterior, and this is typical case again. maybe there is no need to show this structure, but everyone is talking about temporal stem, so I like to show temporal stem. Another case, you see one lesion in the left piriform cortex and another one in the posterior, and extend a little to fusiform gyrus with seizures. This is also only way to go, in my opinion. Supracerebellar transtentorial approach to go there, and this is again the tractography show intact system. This is cavernoma is the easiest one. I recommend the young generation to start with cavernoma because the gliomas are 10 times difficult than cavernoma in this mediobasal temporal region, and this is, and we perform selective hippocampectomy also for seizure control. And also this approach is excellent. I wish I can do much more AVM cases like Michael, and but this is excellent case. This is middle portion of mediobasal temporal region, AVM, young patient. And also the 1 month ago, the AVM bled. Right-sided, it looks like calling me to remove. And the only way to go there is the best way, in my opinion, the less invasive way, so-called, is supracerebellar transtentorial approach, because you can get the feeders in the early phase of surgery. If you go from laterally, you can see the feeders at the end of surgery. But here, the feeders from P2, P3, and so you get P2, P3 in the first part of surgery, and then you can preserve also the vein. So this is the case for supracerebellar transtentorial approach. The location of tumor, AVM, and we have to keep this 3D picture in our brain before we start surgery. And this is craniotomy. I use the linear incision between midline and asterion, and 1/3 is in the upper part of the tentorium or transverse sinus, and 2/3 is lower, and then quadrangular shape craniotomy, 1 burr hole up superior to transverse sinus, 1 burr hole very close to midline, and 1 burr hole asterion. And then we have to release CSF from cisterna magna, and then we can have a relaxed cerebellum. And I think I have some time to show this video. And to check this vein, I tried to preserve them. And this is the tentorial veins. And then depends of this venous anatomy, I modify my tentorial incision. For midbrain or thalamus, I don't need flap tentorium. I just cut the tentorium, just Dr. Lawton mentioned and Mustafa mentioned. But for mediobasal temporal region, I need a flap of tentorium. So I put a suture and I retract the tentorium down and cutting this, and then this is the veins of the tentorium, and I now checking the anatomy. This is P3, and this is posterior part of the parahippocampal gyrus, and I start my incision in the posterior part of parahippocampal gyrus, and you see the P2, P3 junction in subpially. And then I have now control of my surgery, and this is inferior temporal artery, which is main feeders for the AVM. I love to use ICG, but in this case, ICG doesn't show anything. I mean, because of this very small area. So I got one of the main feeders. Just when I start surgery, I got one of main feeder. This is the advantage of this approach. And go ahead and turn around the AVM. And always there are, even you don't see in the angiography, but there are also vessels from middle cerebral artery, because there is a collaterals from middle cerebral artery. So we have to be careful in the lateral side. And again, subpial dissection of the parahippocampal gyrus. And this is choroid plexus now. I am in the ventricle. And the beauty of this approach, again, you always have orientation. You have many landmarks in your surgery. I do not use navigation in this surgery because I have some picture in my brain. I don't want to disturb that picture because this anatomy is there always. And this is roof of the temporal horn. And now I go more laterally. I keep, of course, there is one vein, draining vein, so I keep intact that draining vein. You see hemosterine also. So this is, I am coming to end of surgery. There are lateral branches. And there is still, you see, there are branches from neocortex. So this is the removal of AVM with mediobasal temporal region, parahippocampal gyrus. I do the same thing in the epilepsy cases also. And now I remove the hippocampus. Choroid plexus is here. This is hippocampus, right hippocampus, for prevent also the seizure. And I am checking with the endoscope always. This is choroid plexus, right temporal horn choroid plexus. Amygdala was here. This is tentorium. And I removed the amygdala also. I performed selective amygdala hippocampectomy in the and the internal carotis is here. So, and we perform also intraoperative angiography in this semi-sitting position, even in, because my semi-sitting position is very low. So we always use intraoperative DSA and it looks okay. But later on, you see after 3 months later, you can see the removal of AVM and also as well as selective amygdala hippocampectomy using supracerebellar transtentorial approach. And I use the same approach for the epilepsy cases. I love to do epilepsy, and you can perform the epilectrode, and also this is end of surgery. You see all anatomy. This is tentorium. Amygdala was here. This is roof of the temporal horn, and internal carotid is here. I think I have 5 minutes, Mustafa.
Yes, yes.
Okay, I have to go a little faster. And this is excellent approach for epilepsy cases. And the whole temporal stem is intact. And we published this approach. And what very important point for me that Professor Yashargil gave the idea to me to work on this. And then also he support me to do surgery, and most of the cases, he is in the operating theater, and he accepted this approach. This is most important reward in my life. And this looks also excellent case. This is isthmus cingulate tumor. However, this is the limit of the supracerebellar approach. I use posterior interhemispheric approach in lateral position because this is too much for supracerebellar transtentorial, and this is the isthmus is the limit of the supracerebellar interhemispheric approach, and this is for posterior interhemispheric approach. And after this experience, this is my final thought that if the lesion is in the only anterior part, I use pteronal. But other modification, I mostly prefer posterior interhemispheric approach. Isthmus is our limit. In here, the posterior interhemispheric is better because it's difficult to reach in this portion. It looks like I've solved all problems, but what about this case? Last case, the tumor from piriform cortex to middle portion of the cingulate gyrus. This is, I call C-shaped limbic glioma, but still in the limbic system. But you need something else. One surgery is not enough for this case because that the tumor is in the extending superiorly, and the paramedial tractus is laterally. But there is logic behind this tumor. This tumor is not crazy also, because this tumor is hippocampocentric paralimbic mesocortical tumor, C-shape. This C-shaped tumor can be this system, but still stay in the mesocortex. And in this approach, in this case, I combine two approaches in one session. One incision, semi-sitting position, and posterior interhemispheric, right side, this is posterior interhemispheric approach for cingulate part, and supracerebellar transtentorial approach for inferior part. And in one session, I remove this tumor from piriform cortex to the middle portion of the cingulate gyrus, and still stay in the limbic system, still stay in the mesocortical system, and this is after removal. Okay. So I thank you for your attention. And of course, this is not my work alone. I am working with a great team, and with the also Professor Yaşargil is with us. I'm very happy to host you, I hope, next year in Istanbul because of this COVID-19. So our meeting, we postponed to June 2022. I hope COVID-19 will go away. Thank you for your attention.
Thank you, Uğur. Excellent as always. And anatomical points you made as well taken, and we'll take the questions at the end. As always, I learn a lot from you every time. If you can stop sharing, I can start my talk. So again, I'd like to start thanking Hakan, Professor Hakan Emmez, for organizing this outstanding webinar. It's more than 400 participants. I can see is a very high number, very well attended. And also congratulations on the presidency of Professor Emel Avcı. And I'd like to thank all the participants and distinguished speakers. I'm going to talk about the tricks in microsurgical treatment of vestibular schwannomas. When Hakan asked me tricks, I just came to my mind, maybe I talk about the vestibular schwannomas, but then soon after I hung up the phone, I realized I don't have any tricks. So instead, I thought maybe I should present the basic principles and maybe touch base on some tricks. So I have no disclosures. And this is our lovely city medicine. It's beautiful in this spring and summer. We welcome everybody after this pandemic ends. And again, principle versus tricks versus principle and tricks. I like to use the term basic principles and some tricks. And I like to share how I use these in selection, the treatment. I'm not going to go into the selection treatment between surgery versus gamma knife versus observation. That itself is a matter of hours of discussion. I'll focus on the principles and tricks in surgery of the vestibular schwannomas. What is our goal? Our goal is to get the gross total resection. People call maximal safe resection, but you don't want to start with the defeated strategy. So always, if you are going to do something, go there with your perfect resection and perfect outcome. And when you are doing that, you need to preserve the facial function. If hearing is present, serviceable, you need to preserve the hearing. And at the end, your morbidity complication rate should be small, and mortality is not accepted in these surgeries. So this is the from 1912 paper of Krause, and we made a lot of advances since then. So this is how they were removing, because concern was these were life-preserving surgeries. Now, acoustic neuroma surgery is not a life-preserving surgery. It is a cosmetic surgery. Outcome measures are cosmetic. So what are the microsurgical treatment options we have for vestibular schwannomas? Translabyrinthine approach, middle fossa approach, retrosigmoid approach. I use all these three approaches and depends on the case. And I'm going to just touch base on that, how I select that. And then I want to touch base right now, before I forget, about this hybrid treatment stuff. You don't go there to do subtotal resection, then the radiate. If you're going to radiate, it's small, moderate size, you just radiate. If you're going to do surgery, you just do surgery. But don't go with the idea that I'm going to do subtotal resection, then I'm going to radiate. There is a role of radiation post-surgery in cases that you couldn't remove the tumor safely, but I don't like this idea at all. Okay, I'm not going to discuss about that. So selection of the approach for intracanalicular tumors, middle fossa versus retrosigmoid, if hearing is good, and you then pay attention to do the fundal cap. I'm going to talk about that. And then if there's no hearing and if tumor is intracanalicular and you have to do the surgery, you choose between retrosigmoid and translabyrinthine. My personal approach of choice is translabyrinthine, and I'm going to tell you why. So this is again discussion between retrosigmoid and middle fossa. So this is a similar age patients, 44-year-old, perfect hearing, and you see there's a fundal cap here. That fundal cap is a CSF space at the end of the lateral IAC, and tumor doesn't extend all the way deep laterally in the internal acoustic canal. On the contrary, this one extends, although there is a cisternal portion of the tumor, and many people may not like to do the middle fossa approach in these cases. I selected doing the middle fossa in this one and retrosigmoid in this one because I want to preserve the hearing. Coming very close to the hearing organs here laterally itself damages the hearing. So, but if there is a fundal cap and tumor is not extending laterally, you can remove the tumor growth totally and preserve the hearing. So this is what we did, and this is a between how you choose middle fossa and retrosigmoid in intracanalicular tumors with minimal extension into the cerebellopontine angle. And then selection of approach in large acoustic neuromas is very, I don't want to go through this, but you have two options. If you have good hearing, of course, you're going to do retrosigmoid approach. If hearing is at the borderline and tumor is bigger than 2.5 to 3 centimeter, chance of preserving that hearing is less than 5% in my experience. And in some cases, you can argue against doing retrosigmoid and translab. But poor hearing, my choice is translab always, and I'll tell you why. And level of hearing is important when you're selecting an approach. These are the basics of the decision making. Depth of tumor extension into internal acoustic canal, position of the sigmoid sinus. If sigmoid sinus is very anteriorly located, low and anterior, your mastectomy will be limited. So translabyrinthine approach may not be the good approach. Or on the contrary, it's going to be good for the retrosigmoid approach. But if this is very lateral, very medial, and the low retrosigmoid approach can be challenging. Contracted mastoid, mastoiditis, these are important factors choosing the translabyrinthine approach. And if you have no flow on the contralateral sigmoid sinus and patient is depending on this transverse sigmoid sinus on the side you are operating, then the extensive approach like translab, drilling over the sigmoid sinus and chance of sinus injury, you shouldn't do translab. But tumor size itself is not factor influencing the translabyrinthine versus retrosigmoid approaches, selection of it. So one case, middle fossa approach, good hearing, intracanalicular tumor, perfect hearing, and goal is, this is a cosmetic surgery. Goal is to preserve the function, remove the tumor. Like Dr. Ture said, you are not going to remove the normal, you're going to remove the abnormal. And middle fossa approaches is either straight or slightly question mark incision, completely epidural approach, and we do all these surgeries together with the ENT colleagues. That makes sense because we share the cases, that increases our clinical experience, and also you are sharing the responsibility, and they are perfect. And then you localize the geniculate ganglion with the high facial stimulation, high amplitude facial stimulation. And once you localize it, drilling the internal acoustic canal extradurally, you are retracting the dura. You are not retracting the brain. It makes big difference. And if you need a CSF diversion, and especially in the dominant temporal lobe, in the dominant hemisphere, you use that. And otherwise, you can decompress the CSF right away by opening. And now this is my ENT calling, opening and decompressing the brain. And then at this point, I will enter the case and remove the rest of the tumor. And important anatomical factors, inferior vestibular versus superior vestibular origin of the tumor. Inferior vestibular origin tumors, you may have more difficulty because facial nerve will be hidden by the tumor, and facial nerve will be between you and the tumor. In the superior vestibular tumors, it's much easier middle fossa approach. Debulking, even in the small tumors, is important. The main tricks, if you learn anything from today's presentation, main trick is debulking in acoustic neuromas. Debulk, 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 debulk until you see the normal. This is the facial nerve. It's stimulating nicely, although it's small, it is stuck. And lastly, we cut the superior vestibular nerve, remove. We didn't show the cochlear nerve here. Cochlear nerve is preserved, and during the Bayer's and the cochlear nerve monitoring, there was no change in that. And we had a gross total resection with perfect hearing, perfect face. Retrosigmoid approach is a workhorse of the neurosurgery. We use in many pathologies. Advantages is you are doing it for hearing preservation, for what vestibular schwannomas. You have definitely better exposure and control over the lower cranial nerves, and shorter exposure time. It's in very short period of time you can complete the retrosigmoid, but for translab you need little longer time for them, little longer time than the retrosigmoid. Disadvantage is lateral cerebellum is exposed. You always deal with the cerebellum. You may need to retract the cerebellum, although I don't remember any case I used self-retaining retractors in acoustic neuromas. Poor ventral control and exposure. Main problem for me, if you are doing hearing preservation, inability to expose the lateral few millimeter of the IAC. If you expose, you may cause hearing loss, even from the drilling. Even if you don't damage the cochlea or vestibule, you can get just drilling sound. Being very close to the cochlea, it affects the hearing. And then another significant thing in my experience, 10 to 15% of the patients I operated via retrosigmoid approach, they develop post-craniotomy headaches. Even the bones back, you do beautiful closure. I can explain why. It's similar to the terminal approach. They have a post-craniotomy headaches. And they feel sick first couple of days. Now, this is the case for the retrosig. Again, there's a good fundal cap here, good hearing. So we have to do retrosigmoid in this. And I like to do retrosigmoid approach in spine position. I don't even support the shoulder. We don't have to turn too much. And I like to use C-shape. I learned this from the ENT colleagues, C-shape craniotomy, incision. It relaxes this area much better, and closure is better. And you are not putting the self-retaining retractors if you're using the straight incision in these conditions, and you're using the fish hooks. And then we do all kind of monitoring, including the cochlear and facial. And again, navigation helps you to localize your transverse sigmoid sinus junction. Like Mike said, I like to get a little piece of pericranium, temporalis fascia here. So dura gets contracted at the end of the case, and I like to do watertight closure when dura get contracted. Right, is primary closure is not possible. As you see here, it allows you to use your fish hooks, the wide exposure. Then we're gonna drill the transverse sigmoid sinus junction. I think Mike called this extended retrosigmoid, but to me this is the way we do. I call it just simple retrosigmoid craniotomy, removing the bone flap, and you see you just got the glimpse of the sigmoid sinus, transverse sinus junction, opening the dura. Another, if you call it this trick, first you open the lower end and get the CSF from lateral medullary system that will relax your cerebellum. This is first thing you do, either with, I prefer doing with the microscope. For this recording we did without microscope, I believe. And then protect the cerebellum. We are not gonna use static continuous retraction, but suction is your retraction. And initial surgical attack is release the arachnoid. This basic principle set by Professor Yaşargil, right? Just release the arachnoid. When you apply traction to these nerves, that traction forces are less if you do wide arachnoid dissection. This is not a microvascular decompression surgery, okay? And people use endoscope for this. It's too much traction on the nerves, okay? So if you widely dissect, you move these structures away, and you are freeing them, and you are preserving them. If you do less dissection, arachnoid dissection, you are applying more traction, and there is a chance of injury. And if you are afraid of dissecting these, then you shouldn't be doing this surgery. Okay, this is a cosmetic surgery. You are removing a tumor from the brainstem nerves. Okay, so you need to get better in order to do this. And once you get this arachnoid dissection, identify, preserve the cochlear nerve, preserve the facial nerve. Okay, excellent results. Now we have a translabyrinthine approach. What are the advantages of translabyrinthine approach? You identify all the nerves very early, especially the facial nerve, very early in the canal, and you decompress entire internal acoustic canal. And it's direct way reaching the cerebellopontine angle. Cerebellum is not in your way. You have a presigmoid dura protecting the cerebellum. Even if you cut open that dura, amount of cerebellum you are seeing is minimal. So that's why almost purely epidural approach. And there's a chance of exposing the internal acoustic canal 270 degrees. This is very important. If you do this less, your results will not be good. And probably less chance of CSF leak, wider anterior and superior exposure. I don't remember any patient I did translab and had a postoperative post-craniotomy headaches. Disadvantages, it is difficult to expose some tumors extending too anteriorly. You don't have a good angle. Limited exposure of the inferior part, inferior brainstem, and jugular bulb. If you have a large diverticulum spatial in the jugular bulb, this can be limiting approach. But what we do in those cases, we have a way of doing extraluminal decompression with the little bipolaring and compressing gently. It's something I learned from my ENT colleague, Dr. Mark Pyle. So Position in skin incision doesn't have to be very wide for translap. Very ventral approach, again, supine position. These are long hours of surgery. Doing these surgeries in sitting position, it can be very tiring for ENT surgeons, especially when they drill the translap, and also for neurosurgeons. And our neuroanesthesiologists, they don't like a sitting position that much. And I tell you the truth, supine position is the most comfortable position for me as a surgeon. I get less shoulder pain. And basics of translap: mastectomy first, then taking the semicircular canals. Here they're intact, they're gone, and final exposure should be like this. You see, there is a 270-degree exposure of IHC from everywhere, from Bill's bar to the brainstem. And this is the example, as the size is not important when you are choosing these approaches, translap approaches. What is important is sometimes if you have too much cerebellum wrapping around the tumor, you may not have enough exposure. And in those cases, I stage surgeries. So this is a 23-year-old, not good hearing, and very, very hypervascular tumor. And initial approach is done. We are sectioning the superior vestibular nerve in the canal, and we're gonna find the facial nerve, confirm that with the reader. And I wanted to show you guys in the retrosigmoid what I do once I get this exposure. I stop here now. And you can have very, very rarely aberrant course of facial nerve, or sometimes you think you are operating in the acoustic vestibular schwannoma, and rarely these tumors can be a facial nerve schwannomas without giving any facial nerve presentation. It happened to me 3 times. So you stimulate all surface. You want to be safe first with the facial nerve stimulator. And if it is 100% there is no nerve here, then you want to estimate the course of the facial nerve. And this is something I learned from Taka Fukushima when I watch his surgeries. He cranks the facial nerve stimulator from 0.1, 0.2 to 2, 3, and it starts stimulating very high stimulation. And then you'll eventually, that electricity will transmit and you'll get positive response. And you estimate the correct courses of the true course of the facial nerve. And then after that, you continue tumor resection. Oh man. That is the basics, okay? Debulking, facial nerve stimulation, and debulking is key in these large vestibular schwannomas, and decompressing the lower cranial nerve first, trigeminal nerve, and then continuing debulking. Without dissection, you cannot debulk these tumors, okay? If you just go for hybrid surgery, there's no way you can do hybrid surgery without the dissection. And those hybrid surgeries are sham surgeries most of the time, okay? Not truly hybrid surgeries. So, and we'll find the first 8th nerve. For the young colleagues, finding the 8th nerve is important. You'll have a loop of the anterior inferior cerebellar artery right in front of the 8th nerve, between 8th and 7th nerve. Anterior to that loop, you'll see the facial nerve. Okay, then as much as possible, sharp dissection or semi-sharp dissection. Then, since hearing is not the problem here, we are not trying to preserve, there's no good hearing, we're gonna cut the 8th nerve and eventually remove everything. So I'm gonna, for time being, then I'll keep exchanging my dissection planes between canal and the brainstem, inferior, superior, canal, brainstem. You keep changing it, and then you will find the nerve. Facial nerve course can be anterior, inferior, anterior, superior. I haven't seen any posterior coursing nerve. I think those cases mixed. They are confused with the facial nerve schwannomas. So this is an excellent outcome. grade 2 immediately, grade 1, and long-term follow-up. Again, 5.5 centimeter cystic schwannoma, very high extension superiorly and hydrocephaly. This case, we talk about the two-stage doing it because it's long hours of exposure, translab, and I always consult patients possibility of the 2 stages because I don't want to do these surgeries 3 a.m., 4 a.m. and then that's the most difficult part of the surgery. You can stop and come back, like Dr. MFT does some of his cases. So this wasn't a problem, it was a cystic, and we were able to get halting out in 1 stage, I believe 15-hour surgery, and he did very well. Although he required shunt because of persistent ventriculomegaly. And then this is another one, again, very large, 4 centimeters cystic schwannoma. Cystic schwannomas are notorious for being stuck to the nerves and the brainstem. In my experience, 50-50. In some of them I find stuck, some of them not. So again, another, size is not the matter. And translab is the best approach for tumors that were operated before via retrosigmoid approach, okay? And this is the perfect cases. See, this is a moderate size, 2 centimeter acoustic retrosigmoid, although the patient had a good hearing, and they do retrosigmoid. After the surgery, she lost her hearing, and this is almost like a planned hybrid surgery, but patient developed trigeminal neuralgia 1.5 years after the surgery, and then tumors start growing a little bit. And in spite of all these medications, her trigeminal neuralgia became intractable, and many discussion, gamma knife versus microsurgery. I said we can decompress this trigeminal nerve easily and remove it and cure the thing. Patient didn't believe because this patient had a first surgery in a mecca of acoustic neuroma surgery. Okay, they don't believe you, but eventually she agreed. And we did the translab approach, okay, as routine stuff. And in some of these tumors, I cut the part of the presigmoid dura. You see, this is the superior vestibular nerve here. This is the facial nerve, and sharp dissection or semi-sharp. And once you free, you make sure you cut the superior vestibular nerve and debulk. Even if the tumor is not big, is debulk. Here in this case, dissecting the facial nerve wasn't that difficult, but the trigeminal nerve was crushed by the tumor, even the small size. So finding the facial nerve at the brainstem site and connecting 2 planes. And I'm using arachnoid diamond knife here, okay? And debulking. Don't be ambitious, impatient, just trying to remove everything en bloc or big pieces. Just make the tumor smaller, you'll see better, you have better dissection planes, and you are devascularizing the tumor by removing 2. So again, this is a sharp dissection, semi-sharp dissectors. I found these dissectors very, very useful, and last attachment of the facial nerve here, and again, removing it. It is, and you keep checking. And if you need to irrigate with the warm irrigation. Cold irrigation irritates the facial nerve. And if your stimulation getting low and you are not getting stimulation, and the nerve looks good, use sodium nitroprusside to prevent the microspasm of the nerve. See, this is the trigeminal nerve, is very adherent, very stuck to the trigeminal nerve. I am applying forces. Trigeminal nerve tolerates this, but facial nerve will not tolerate this kind of traction. Okay. And finally, removing everything and the rest of the tumor. Perfect outcome. She doesn't use any medications anymore. Trigeminal neuralgia completely resolved, good facial outcome, and she's cured. Okay. So this is another example of translab. First, they do retrosigmoid, tumors start growing, they recommend radiation, and he came to see me as a second opinion. I said no, and then you can watch this video. Perfect for translab. You come fresh, you don't use the retrosigmoid approach, and patient didn't have any good hearing anyway. So another patient from Spain, they removed 2.5 centimeter tumor, good job, but they left the canalicular part, and then they gamma knife this, and then after the gamma knife, tumors start growing, and he start having, I think, either numbness in the face or something like that, and we did the gross total resection, grade 3 immediate post-op, grade 1 and late post-op, and same story, subtotal resection, hybrid surgery, cyberknife, and tumor grows after cyberknife, and we remove it. Another interesting case, they open retrosig, cerebellum is quite swollen because patient has hydrocephaly, right? It's simple. So then they abort the surgery, and we remove the tumor with translab. And this is a translab is also good for the post-radiation cases. Again, post-radiation, tumor continues to grow after the radiation, and we remove gross totally. This is not grade 1, this is grade 2, but she's happy, tumor is off. If you remove the entire tumor, there's a Mayo Clinic study by Mike Link. Patients psychologically do better. They feel better if their tumor is out, even with the mild facial weakness. Stage surgery in a very large emergency cases. So I like stage surgery in everything, because I think as we get older, we get tired, right? And also it's good, you rest, and then sometimes ENT, I do all these surgeries with ENT colleagues. That's our deal. So, but arranging translab in the middle of night is difficult, and arranging ENT surgeons is very difficult setting up. So this patient comes with the sudden facial numbness and sensory neural hearing loss and severe headache, okay? So CAT scan shows CP angle tumor with minimal hemorrhages, and MRI confirms internal bleed of the tumor, and due to that, significant brainstem compression. And this patient needs immediate decompression. And I don't want to spend in the middle of night or unprepared with ENT for translab 10 hours, okay, with the personnel who are not familiar with these surgeries. Okay, so what I do, I decompress. First stage retrosigmoid, second stage came back fresh with the ENT colleagues and removed the rest of the tumor via translab. And also I found if you give few days to let the patient rest, also tumor gets less vascular on these cases. That's my experience. I cannot substantiate this with any data. See, it's a sharp dissection or blunt dissection, trying to preserve the peeled plane, and then after that, debulking, going to the facial nerve. See, this is a nervous intermedius joining the facial nerve there. And some large tumors, you can preserve nervous intermedius, but some large tumors, you don't even see the nervous intermedius. So, and this is the tumor resection from the brainstem, same microsurgical principles, going between internal acoustic canal and then the brainstem, okay? 2 stages. I didn't get tired, patient didn't get tired, not too long anesthesia, and we need to do the emergency decompression for this bleeding, intratumoral bleeding. So this is another one, again, came with the hydrocephaly, middle of night, we put the ventric, patient is very symptomatic from that, and did the retrosigmoid, This is actually last week. And then he woke up with the grade 3, is almost grade 2 now, is still in the hospital. This is last week, gross total resection. And this is an unforgotten nerve, okay? This is, everybody forgets about the nervus intermedius. It's very small nerve, and in moderate size schwannomas, you can preserve it. In large size schwannomas, if you can see, you can maybe preserve, but most of the time in large acoustic neuromas, you don't see the nervus intermedius. And it can be very disabling. A patient looks perfect, right? You preserve face, everything is look good, tumor is gone. They report you, they don't taste well. They cannot taste anything. So, and this is the case to demonstrate you to translab approach with this moderate size, small to moderate size schwannoma, and identifying the nervus intermedius. Okay, so it's all epidural. You don't see cerebellum. Okay, this is the canal is already drilled. This is the tumor in the internal acoustic canal. Initial debulking. Okay, I'm sorry, I'm taking too much time. And debulking, and hearing is already gone. We don't worry about that. And finding the 8th cranial nerve. Once you find the 8th cranial nerve, you're gonna find the 7th cranial nerve. Okay, now we're gonna cut the 8th cranial nerve, and in front of the 8th cranial nerve, anterior, there will be Aica loop, vessel loop between facial and the see that's the loop. This in this case is quite small, and this is nervus intermedius. See, it's not going to stimulate with the facial nerve stimulator if you are not too close. See the loop and debulking, and sharp and blunt dissection around the tumor. Sharp or semi-sharp dissection around the nerves. Okay, not pulling, not applying forces. Okay, see, this is a large vein. We preserve the normal, remove the pathology. Okay, and see, everything will be preserved. At the end, you'll see the facial nerve like this. Okay. So pre-op, post-op, and we specifically asked them test his taste. He tastes perfectly fine. So, what are in summary, general principles? Correct selection of the patient, correct selection of the approach, and sometimes stage approach, and rarely. And the hearing and facial nerve status is very important. You need to be aware some of these schwannomas can be facial nerve schwannoma or lower cranial nerve schwannomas. Anatomy is everything. Correct surgeon decision, right? Maximal safe resection versus hybrid. You go there with the gross total resection goal. If tumor is very stuck and you are losing the facial nerve stimulation, then you can leave the tumor behind, and that's a devascularized tumor. The regrowth of that residual is very small chance. I don't like radiating right away. I will wait. I'll only radiate if that remnant grows. And intraoperative CSF drainage, lumbar drainage, early sternal, and early localization of the facial nerve, and using the sodium nitroprusside to prevent vasospasm, warm irrigation, and preservation of the nervus intermedius. Intraoperatively again, and CSF leak is a problem for translap. I like to put lumbar drains and the fat graft from the abdomen, and you need that. Postoperatively, facial nerve is a problem. We like to put all patients after resection 1 week course of the antiviral therapy to prevent the delayed cranial nerve pulses. I never seen a delayed abducens nerve. I've seen a delayed facial nerve palsy after acoustic neuroma surgery. We had one case we published, and what about the results, right? And also, I don't see any difference between cystic versus solid vestibular schwannomas. All comers, large acoustics in vestibular schwannomas, either I did translap, retrosigmoid, or stage surgeries. Our facial nerve function rate is over 500 cases now. Grade 1 to 2 is more than 90%. And smaller tumors, 98%. I have one patient with the facial, and that's why it's 98%, okay? And if you include the grade 3s, these rates will be much better. So, for the young colleagues, read, listen, watch, dissect, okay? Laboratory practice is extremely important. You need to spend time to learn these complex anatomies of the brainstem, complex anatomies of the AVMs, complex anatomy of the mediobasal temporal region. I did it this time, mediobasal. I didn't say mesial. I don't want to upset my brother, Uğur. And like always, we follow the principles of Yaşargil, okay? Go to lab, learn, dissect, watch, and then go practice in the real time. And then we have a skull-based course. It's going to be virtual. I will be performing all these dissections. Everybody is welcomed. And thank you for taking too much time. I'll stop sharing, and then I'll go to the questions right away. First of all, let's ask the distinguished speakers, Professor Ture, Professor Lanzino. I think Mike left. Would you like to comment on Giuseppe's AVM surgery, my crazy translab cases? So, and Giuseppe, same for you. Any comments on Uğur's presentation, Mike's, mine? Please feel free to share your opinions and comments and questions. Professor Ture.
First of all, Mustafa, I listened you first time about vestibular schwannoma lecture, and I'm not exaggerating. I am very impressed. First of all, for me, I tried everything in vestibular schwannoma, and now I use semi-sitting position in vestibular schwannoma surgery, last 15 years. And I saw that vestibular schwannoma surgery can be done in perfect way, even in supine position. First time in my life. I congratulate you. I couldn't imagine that these cases can be done in supine position. Really, congratulate you. I'm very impressed. I mean, I did in lateral and supine, but I use semi-sitting, but you showed beautifully that it can be done. And this is my congratulations to you. And also that middle fossa approach, also I saw from best people from middle fossa approach to acoustic, and I never use. But I learned today that there are indications for middle fossa approach also. Congratulate you, very well done surgery. Thank you very much.
Hearing from you means a lot, you know that. And regarding the Giuseppe's or Mike's talks, Professor Ture, do you have any comments?
Yeah, I mean, Giuseppe, when I listened to Giuseppe, I said, okay, I should not give a lecture because he just construct the lecture for tricks in surgery. You know, when I listened his lecture, I said, okay, I am so late to change my talk. Or I am so late to construct my talk. His talk was excellent, just to talk about tricks and tips in AVM surgery. And so I felt very bad when I listened to his lecture. And about Michael, you know, I love to listen to Michael because I love semi-sitting position, and he is one of the best in the world. And I mean, almost 90% of what he's telling is, I'm totally agree. I have some points that maybe we can discuss, but he's not here, so we cannot discuss. But I'm very happy to listen his lecture always, especially to bring in a semi-sitting position to back. You know, we are planning to do next year with Giuseppe. I hope we can do it in Istanbul to meet, because semi-sitting position is totally abandoned. This is not fair. You know, of course, you know, in the past there were some problems, but in modern neuroanesthesiology, now we can use the advantage of semi-sitting position, and we can decrease the disadvantage of semi-sitting position to choose correct cases, and also prepare the patient very well. And I'm very happy to listen all of your lectures. I learned a lot, at least. This is my side. And I'm very happy to be faculty in this session. And I like to congratulate again Dr. Avcı and MS. You know, the IBNC course, founder of IBNC course was Dr. Murat Balbek. He was our president of Turkish Neurosurgical Society. And now the new, and then Dr. Solaroğlu was the one first construct this meeting, and I try to also improve. And now the new team, new Turkish Neurosurgical Society team, brought this IBNC course as an international, well-established course. I congratulate all team, and I am proud of them. Thank you very much.
Thank you, Professor Tre. Giuseppe?
Hey, I like to echo what has been said. First of all, congratulations. This was an incredible session. The fact that you had more than 400 participants. I have a question for Professor Ture. Ugur, more than anyone else, you have had a chance to spend so much time with Professor Yasergil. When it comes to AVM, can you tell us some of the basic, concepts that you have learned from him that you think are really have been fundamental? Because sometimes my experience with AVM has been like you learn, you watch surgery, then you start doing it, then you go back and you read the books again and say, oh, I understand what he means, but it's just in one sentence. And when you read and you are studying, that sentence doesn't hit. Like the concept of the ventricle, it took me a while to understand. But then after I noticed, I went back and then I understood. You say, when you have deep feeders, if they come from the ventricle, you just go there first. For whatever reason, it's much easier to deal there than. So what are some of the concepts, basic concepts that you say like pearls that you have learned among many?
I mean, I have to talk 1 hour, but what I have to tell you, when you ask this question, Professor Yasergil is with us last 6 years, and he was watching my surgeries, and then he start to select the cases, not every cases. So, and last 1 year, he's, mostly staying at home because of COVID-19. He got tired, but he wants to come to hospital, but I said, please stay. But fortunately, he got vaccination 1 month ago, and he's ready to come every day. But anyway, during this time, when I do AVM, he wants to come. AVM, he never missed AVM. And next week I have large AVM, and I was planning to do yesterday, but I cancel it, I postpone it. And he's asking me when you are operating AVM, when you are operating AVM. So he will be with us in AVM. In every AVM surgery, last 15 years, I did with him. Can you imagine? This was great stress, but just opposite. It was great chance for me. And he's in every AVM surgery, he was in operating theater. And in every AVM surgery, I feel that I am just learning. And every case, every point, he gets some tricks, and he never disturbs me. He doesn't talk in the operating theater. In his operating theater, nobody could talk, in Zurich, in Mediobasal. In the same, when he is in operating theater, in my operating theater, he also doesn't talk. He respects surgeon. he doesn't disturb the surgeon. But I ask sometimes, and he gave some tricks, and it's very, very important point for me to do surgery, AVM surgery with him. But generally, you know, he wrote everything in his book. But one thing is very important to decision of AVM surgery: which case we should operate and which case we should not, which is not very clear maybe in his book. Most important trick is the patient venous system. He looks to venous system. If there is a problem in venous system, if there is obstruction in venous system, he told me I have to operate. Even I had some cases, that crazy cases, I was not planning to operate, and he told me I have to operate. Especially the sinus rectus, you know, because the deep venous system can get the sinus rectus, but in that point, that sinus rectus cannot enlarge. Same thing in the superior sagittal sinus. If there are many veins goes to the superior sagittal sinus trying to go, and if you look the angiography, there is narrow connection between the superior sagittal sinus and the draining veins. Or same thing in the deep venous system, reach the sinus rectus. These cases, he told me that this is the most important indication for surgery, for treatment of AVM cases, even not ruptured or doesn't matter. So this is very important trick for me to do, to decide surgery for AVM, even large grades AVM. But one thing is very important. You mentioned that there are always, at the end of surgery, there are always some small feeding arteries just underneath the draining vein. This is also, you showed very well. And also very important to use this temporary clips, but also we need permanent clip. Yaşargil have a permanent Yaşargil AVM clip. And then he produced for himself, but now the Kopitnik system is done. But still, that AVM clips, mini clips are not titanium. And the big companies doesn't produce titanium mini AVM clips because sometimes you have to leave it. But to put such a big aneurysm clip in AVM is crazy. We should leave maybe very small AVM titanium clip, which does not exist. But in Brazil, there is one company, they produced titanium mini AVM clip. So this is an important point because otherwise, if you leave mini AVM clip, it destroys the postoperative MRI. But generally, what you mentioned was excellent. But we can continue to talk about it. It's always fun. And as I told you, that Professor Yaşargil is always enjoy to continue to AVM surgery because the AVM is surgical case. Endovascularly, how many percent of AVM you can close it? And if you don't close totally, it is dangerous. It's more dangerous. And gamma knife is how many percent of cases gamma knife is effective. And I have many cases that after gamma knife, we should perform also the surgery. If possible, AVM is this microsurgical case, if possible.
Giuseppe?
Agree. I agree with that statement. As you all know, I'm a strong proponent of endovascular for other lesions, but I think that, of course, embolization has a role in AVM treatment, but in my own institution, it's a relatively limited role for AVMs because, yeah, you would like to close those deep feeders if you can, but those are also the ones that if you try to embolize, that's when you get a complication. And then the other limited role in our institution is that there are some of these very large AVMs where I feel if you can safely embolize some of the feeders and in a way prepare the brain over a course of a week, 10 days, so it's not a massive hemodynamic derangement, I think there is a theoretical role. And then the last way that we use embolization is that sometimes you have a complex AVM, patients with the rupture, you see the pseudoaneurysm, so you can target that pedicle, close the pseudoaneurysm, and then deal with the AVM at the later time. So we don't use embolization for cure, except for exceptional case where the AVM is very, very small. We don't try transvenous embolization, and all cases that I have seen myself visiting other colleagues or being part of live cases where they are embolizing AVM for cure, there is a point where you take a chance. And I don't like to take chances. You know, I don't like to say, because when you try to go for cure, there is a point where you are almost there, but the AVM is still alive. And then two things can happen. Either you close it or it might burst and bleed. And I don't like that random factor. And as Ugur say, there are very other options, and I am a strong believer that surgery still has a very important role.
Thank you, Giuseppe. I wholeheartedly agree. And I think AVMs, most of the, AVMs are surgical, some not. And the most important decision, I think, is to decide which ones you're going to operate. The venous outlet stenosis or obstruction is the key. And only I have one patient I did not operate because family was on the fence and he didn't agree. And I said, okay, maybe you should have gamma knife. The gamma knife, and 6 months later, patient bled, not because of the gamma knife, because of the stenosis of the venous outlet. And then, like Ur said, is like through the straight sinus. So it's sometimes decisions are more important than the surgical techniques.
Yeah. If you remember what I said I would be lying if I say that I have learned how to decide. And there are cases where still, I don't know exactly what is the right thing to do. And that's particularly true when you have a patient with the complex AVM and you look and you know you can do it. But if the patient, nowadays, many of these patients are completely intact, you have almost like a psychological block because you are afraid of giving a deficit. And I have had that experience that probably is common to several of you, is that sometimes the same patient comes back with the minor bleed and then you are forced to operate and then it goes well. And you say, wow, I wonder how many. So it's a very, yes, Michael has done a great job with the grading system. But there are a lot of commonalities in AVMs, but there are also so many differences depending on the AVM, the patient, the angioarchitecture, the environment, that as I said, I would be lying if I say, oh, this is how you decide, and I know how to decide in every single case. It's very difficult.
100% agree. Let's go to the questions left for the speakers. Dr. Kartal is asking, has anyone experienced doing AVM surgery with an exoscope? Do you think that is superior to the conventional microsurgical technique? Would appreciate some comments.
Yeah, we had Jack Marcos a couple of days ago organized a webinar, and David Langer from New York showed his experience with the exoscope. And he's a strong proponent. He showed he had done some cases of AVMs. I think the problem for the panelist in this webinar that he said the exoscope, it's not good for the mouthpiece surgeon. because the aesoscope, you can move it to some extent, but it's not as easy. If you're used to stay on focus and move with the mouthpiece, the aesoscope tends to be more of a fixed aid. There is no question that some of the optics with more advanced, they're getting better. I think the aesoscope where I see a role, if you think about, is for STA-MCA bypass, because it's a surgery where you tend to stay focused on the same field. It's a very small field, and to have an aid that increase the definition and the magnification can be helpful. But David, I don't have experience with AVM. David Langer has, so it can be done. But he specifically says the exoscope is not for the mouthpiece surgeon because it's a completely different mindset.
Yeah, I mean, it's not only completely different mindset. I think to me, I tried many exoscope. I find it disabling to use the exoscope because you are not, and certain pathologies on the surface, I understand. Spine, I understand, or something, but I like to see what I am doing. I don't want to see that through, looking like this. And they say surgeon's posture is better. I don't have any posture problems. I play soccer every week, so I disagree. But I know Ur he got excited. He wants to say something.
I don't know what can I say. I couldn't understand the reason behind to using exoscope as a neurosurgeon. Eye surgeon maybe use it, or ENT for ear may use it because they don't move it and it's flat space. But we are working on one globe, we have to turn around. To use mouse switch is not my fault or my deficit. We have to use it to turn around the lesion. I would like to ask you, if you are a Formula One pilot, do you use screen in the game instead of looking with your eyes? Do you use it? If you are a Formula One pilot, do you use it? Do you know what I mean? If you use your car with 300 kilometers per hour, and in the Formula One, can you use screen, even the highest definition of screen in your race? We are Formula One pilot. We cannot use screen in all length of surgery, and I couldn't understand the reason, because even the highest definition, they have now 8K, but our eyes is more than 32, and with the microscope we have magnification highest. We have to be not microsurgeon, we have to be nanosurgeon. Next generation should be nanosurgeon, but now getting worse. I couldn't understand the reason. Sorry.
I cannot either. I am with you on that. And Dr. Gupta asking for Dr. Lanzino, please comment on normal perfusion breakthrough phenomenon. Does it actually occur, or is it because of the bad dissection?
Yeah, well, I think that the issue of postoperative hemorrhage after AVM surgery, it's fairly complicated. The normal perfusion breakthrough theory made a lot of sense, but I start suspecting that some of those postoperative hemorrhage that we have seen and that they are reported, some can be hemorrhage. Actually, they can start during the dissection, either because of retained nidus or because you coagulating one of those deep perforators, it retracts in the brain. You don't see any obvious bleeding, but the brain starts swelling, and then you might see afterwards. Another possible mechanism is that what the theory of the passive basically that the thrombosis in the veins that you promote by removing the AVMs might extend to normal veins, and that might also trigger. So I think it's most likely there are different possible reasons, more commonly a small retained nidus in absence of a venous outflow. And I start questioning in my mind whether the true perfusion pressure breakthrough exists. The other thing is that with these some very complex large AVMs where you are more likely to see it, nowadays we tend to do embolization. So as I said, we kind of tend to prepare gradually the brain to the massive derangement or removing that AVM.
Thank you, Giuseppe. For time concerns, I have one or two questions for Therese. Some of them he answered actually during his lecture. Dr. Deniz Nerdenyan from Germany is asking, are the beautiful dissection of Professor Ture in a published paper? If yes, which is the title? Thank you very much.
Pardon, what was the question?
Your dissection, anatomical dissection, is in a published paper.
I published some, but most of them not yet.
Correct.
I need a smart fellow to work on. Smart fellow. I need.
And then
I have many things to publish. Yeah.
Professor Ta is asking, for the temporal AVM, why do you do ablation of amygdala and hippocampus? Is it because the patient had an epilepsy?
Yes. Yes, it is hippocampal AVM. You have to do, if there is a hippocampal tumor, I also remove the rest of the hippocampus to prevent the seizure.
Okay. And there are a couple of questions for me. Dr. Gupta is asking, sir, approaching bilateral vestibular schwannomas. That's a very complex question. Excellent question. If it is neurofibromatosis, is again hours of discussion, and you can read all these in the books too. For if there is a hearing, I'd like to preserve the hearing and be more conservative in bilateral schwannomas. Okay, I wouldn't just jump and do surgery because you don't know of the outcome on that side, and then the other side starts growing. So you need to be very careful. For me, again, do you usually drill internal acoustic canal before or after tumor debulking retrosigmoid approach? In the retrosigmoid approach, we like to drill the IAC after the initial debulking, removing most of the cysternal segment. That will release the pressure on the cerebellum, as well as the any mistake with the drilling, you can catch the tumor and cause bleeding. And as also you see the anatomy much better after debulking. Do you use total petrosectomy? No, never. I mean, why do you need total petrosectomy? Dr. Eduardo Valladares wants Dr. Ture's email. You can request that from the organizers. He wants to come and make a rotation with you, Uğur. He's a 50-year resident.
Yeah,
and how you find the jugular foramen and the MRI? I mean, jugular foramen, jugular bulb is very obvious, and if it is high, you'll see that right away. And jugular bulb is not good for retrosigmoid or translap. It has problems. It's in both approaches, but in the translap you have a chance of extraluminally decompressing with the little coagulation and compression with the Surgicel and the pedis. What is your explanation that resection half of the tumor by 2 stages make them worse as meningiomas? We see that in the brain become angry and oedematous. Now, actually, in the contrary, these tumors, there are different pathologies. Okay, so leaving the tumor behind for staging is a concern. If you didn't devascularize the tumor enough, you can have a bleeding in the residual tumor. That's true in many gliomas, many tumors. But if you do the way you devascularize, not just go debulk, devascularize, spend time, dissect around. Acoustic neuromas have 2 vascularity, okay? extradural and around the porous acousticus, internal acoustic canal, and then intradural feeders that directly come from the anterior inferior cerebellar artery. If you take direct feeders and devascularize, I haven't seen any residual tumor. I left that bled, but I don't do the compression like removing the 20-30% of the tumor. I do the compression when I do retrosigmoid in 4 centimeter tumor. I will remove at least 70% of it, 60-70 minimum, and then devascularize the tumor. Okay, so what do you think targeted therapy for high-grade AVM? I don't know what you mean from the targeted therapy, gene therapy. Please, could you share your experience in timing of surgery in ruptured AVM, acute versus delayed? Giuseppe, would you like to take this question?
Yeah, I think it's there is not a right or wrong answer. It depends on the complexity of the AVM and your experience and degree of comfort operating on an AVM in a situation where you have a swollen brain and the planes are not that visible. There is really the risk of re-rupture of an AVM over a short term, if unless there is an aneurysm, associated aneurysm that bled, it's extremely low. The AVMs that rupture shortly after a first bleed are the ones where you do the angiogram and you see, as Ugur said, there is obvious, there is a single vein and there is outflow obstruction of that vein, often with the varix. Well, those are emergency situations. Outside of those, when to operate on an AVM, as I said, it's a matter of AVM complexity, I think, and your experience and degree of comfort. However, we also need to, we cannot use the excuse of the patient having a deficit from the bleed as a poor long-term outcome, because as we know, many of these patients that present with important deficits after hemorrhage of AVM, if you wait, those patients often they recover from their neurological deficits. So I don't think there is a right and wrong answers. Of course, people have reported operating on complex AVMs acutely. If the AVM is complex, it's not something I would suggest. And if the patient is in extremis, you can remove the hematoma, leave the AVM alone unless you get into intraoperative bleeding and deal with that at a later time.
Yeah. Yeah, I will do only emergency surgery if, emergently remove the AVM if it's simple AVM on the surface next to the hematoma, and you need to decompress the hematoma and you are not going to spend too much time. You can remove the AVM emergently with the evacuation of the hematoma, but I wouldn't suggest in the complex AVM doing in the middle of night, especially you do these surgeries. So, Dr. Kaan Yağmurlu is asking for Professor Turia, have you had any case of limbic paralimbic tumor that invades the neocortex in the temporal lobe?
Yes. Yeah, there are also gliomatosis cerebri. You know, this is, but I am talking generally, but there are some cases that the tumor is whole temporal lobe. Yes, there are some cases, but they are rare. They are rare.
Correct.
There are also multifocal GBMs.
Correct.
There are also gliomatosis cerebri. But this is, I
Maybe.
am just telling that general concept is,
correct.
you know, limbic
Correct.
system. Neocortical tumor stays in the neocortex. Limbic tumor stays in the limbic. This is general concept, not rule, not every, because there are also multifocal GBMs that you cannot put any rules, you know, it doesn't listen to any rules.
So I agree. And then the late phases of GBMs, great for astrocytomas, there's nothing, they don't follow any rules.
Yeah, they don't follow. Yeah.
So, and then Turab Gasimov is asking, do you have any experience with surgical nervous intermedius neuralgia cases? Tell you the truth, I don't, because those cases done by different surgeons, and I wish I could do the microvascular decompression at least once in a week. Is very pleasant surgery, but I don't get those cases. So, and lastly, Gıyas Ayberk is asking doxycycline, MP9 inhibitors, or thalidomide therapy as immunomodulator. I'm sorry, but I'm not aware of any this kind of things, and I have no knowledge on these. Giuseppe, do you have any?
No, it's I know that at one point there was a discussion about doing a trial of Avastin for untreatable AVMs. We have a fairly large population of patients with hemorrhagic telangiectasia, and I know that for some of those superficial AVMs, they are trying targeted drug therapy. They've told me about some cases that they've seen actually of regression of the AVMs. I don't have any experience for brain AVMs. I'm not sure if anybody has done it or is doing it.
I think there's problem with Dr. Başkaya internet connection.
Mustafa? Yeah.
I have to apologize. We have a case going, so I need to leave. But thank you very much, everybody, and
Thanks a lot.
great to see
was great.
everybody.
Thanks a lot.
Congratulations again.
Thank you, Giuseppe. Thank you very much.
Başkaya left because of the connection, so it's time for
I
me
think
to.
it's time to left for us also.
We listened to 4 great lectures.
Mm.
Thanks to all lecturers and participants. It was enjoying and we learned a lot. Thanks for all.
Congratulations.
Nice and happy day. Bye.
Congratulations.
Bye.
Bye.